Respected patron, respected teachers, senior colleagues and postgraduates, we have assembled here, good evening to all. We have assembled here for our monthly CME meeting. This is the first meeting in this year, 2025. And actually this meeting was supposed to be conducted in the month of November. Due to various reasons, it got postponed, and we are having this meeting now. And without wasting much time, we'll go ahead with the meeting. May I now call upon Dr. Malarvili and to come and take over and conduct the proceeding. The other two chairpersons are yet to arrive. Anyway, we'll go ahead with the meeting.
Good evening, one and all. Welcome you all for the first CME of this year, 2025. We have an interesting postgraduate session. To start the session, it is a topic presentation by Dr. Muthukumar, a case of megacolon from SIMS Hospital.
Good evening, teachers and friends. Today I am going to discuss an interesting case of toxic megacolon from Department of Medical Gastroenterology, SIMS Hospital. Here we have a patient, Mr. X, 36-year-old male from Chennai, unmarried, marketing executives are working. So he came to our hospital with history of loose stools, fever, lower abdomen pain for 7 days, and abdomen distension for 2 days. So history of presenting illness, the loose stools started, history of loose stools for 7 days, which is started in the first week of October. Acute onset 6 to 8 episodes per day, nocturnal episodes around 1 to 2 per day, small volume, Bristol type 7 along with blood and mucus, associated with urgency and tenesmus, fever which is intermittent, not associated with chills. Then he had a history of abdominal pain, mainly in the hypogastric and left iliac fossa, which is acute onset, intermittent, crampy pain, pain scale of 4/10, not radiating. Pain decrease after defecation. This pain not related to food, not associated with vomiting and abdomen distension. First, before he came to SIMS Hospital, he was treated outside the hospital with IV fluids and IV antibiotics, piperacillin, desobactam and metronidazole. When we receive in emergency room, with a history of frequency of loose stools which decreased to 2 to 3 per day, with blood and mucus, associated with abdominal distension, which is acute in onset, progressive, more generalized, not associated with vomiting. There is no history of outside food intake, no history of travel, no history of chronic NSAID intake prior to the illness, no history of skin rashes, joint pain, oral ulcer and redness of eyes and genital ulcer, no history of consumption of canned food, and no history of oliguria. In past history, is nil significant. Family history, no history of similar illness in the family members. Personal history, there is no history of high risk behavior. The summary of my patient is 36-year-old male without any comorbidities, presented with fever, small volume loose stools along with blood and mucus, large bowel type, with low abdomen pain for 7 days and acute onset abdomen distension for 2 days. There is no other positive history. His general examination is conscious, oriented, moderately built and nourished, BMI of 24, a mild tachycardia was there, 104 per minute, no fever, mild pedal edema was there, no signs of dehydration, no cutaneous markers for IBD. So abdomen examination is of diffuse tenderness all over the abdomen, no rebound, no guarding, auscultation, bowel sounds are sluggish. Perectal examination, glove stained with blood and mucus, no perianal skin tag and fissure or fistula. His initial blood investigation showed a low hemoglobin of 9.9 with WBC count of 10,440. It's slightly elevated platelet count 3.2 lakhs and low potassium of 3.2. And LFT normal, essentially normal except hypoalbuminemia, which is 1.9. Stool routine examination with plenty of RBC and mucus was present. Stool culture negative, stool for Clostridium difficile toxin A and B and GDH were negative. Then his iron and transferrin saturation of 16 and 16. And fecal calprotectin is 882. and we took biopsy from CME PCR from colonic biopsy, which is negative. On day of admission, we did a sigmoidoscopy without preparation. You can see deep, slightly excavated ulcer with overlying otitis exudate in the sigmoid as well as in the rectum. We took biopsies. So histology shows for both acute inflammatory as well as chronic inflammatory changes. So there is crypt architecture distortion displaying elongation, dilatation of crypts with mucodepletion and focal loss of crypts. Foci of ulceration, which is covered by acute inflammatory X-rays and some inflammatory infiltrates. The impression, foci of ulceration with moderately chronic active inflammation with mild prominence of eosinophils and focal candida colonization. Then we did a CT. We can see the hugely dilated transverse colon, which is about 10.4 centimeter. The official report from our radiologist, diffuse circumferential wall thickening with submucosal edema in the cecum, ascending colon hepatic flexure, splenic flexure, descending colon sigmoid and rectum, surrounding fat, periserosal fat standing. The markedly dilated transverse colon about 10.4 centimeter. This is follow-up CT of my patient, which is the longest transverse colon diameter, which was encountered around 14.5 centimeter. This is the course of our patient in our hospital. First week, he presented with a large bowel type of diarrhea. The outside they treated with IV antibiotics. Then he developed acute onset pain and distension. So second week he referred to our hospital. So we did a sigmoidoscopy. We treated with IV hydrocortisone of 100 milligram IV 6th hourly. Then third week he persists to have abdominal distension and not responding to the hydrocortisone. So we started him on infliximab induction dose 5 milligram per kg. Despite inflix biologics, he also doesn't respond to the treatment, progressive abdominal distension, tachycardia, fever. So finally we proceeded with subtotal colectomy. Meanwhile, his albumin was corrected and potassium correction also given. This is the subtotal colectomy specimen. So macroscopic examination, extensive pseudopolyps. The crypt changes such as distortion, focal displaying, branches dilated with mild mucodepletion, and the lamina propria inflammation as well as that. There is no epithelial granuloma or parasites. So final diagnosis were made IBD complicated by toxic megacolon. Some few literature about TNF response failure. They mainly the high inflammatory burden, low albumin level, high baseline CRP, male gender, high body mass index. These are the some index which can predict the low responsiveness to the infliximab. The American Society of Colorectal Surgeons and practical guidelines for surgical management of ulcerative colitis. They have suggest severely indication for surgery is the severely medically refracted ulcerative colitis, fulminant colitis, toxic colon, colonic perforation should be undergo total abdominal colectomy with endoileostomy. But whether we can do a total proctectomy with ileal pouch anal anastomosis depends on patient history, whether he completed family. So that should be decided on whether a type of surgery has to be done. So since our patient young male not completed family, so we proceeded with subtotal colectomy with the endoileostomy. So learning points, whether unresponsiveness of large bowel diarrhea should suspect ulcerative colitis. Decreased frequency of loose stools with abdominal pain, suspect complications such as megacolon. Sigmoidoscopy with biopsy usually unprepares the diagnostic methods. Rescue therapy, we have biologics as well as upcoming small molecules, tofacitinib. Surgery, IAPP versus colectomy decided by patient symptoms as well as younger age of the patient. Thank you.
Thank you, doctor. This is the first index presentation.
Yes,
he is not a known case of an inflammatory bowel disease. Okay. Did you search for any literature as like a first presentation of an acute severe ulcerative colitis as toxic megacolon? Any literature evidence you have searched for?
I didn't search.
Any other questions from the?
First 6 to 8 ma'am.
I was just wondering, no, the clinical presentation, the 6 to 8 episodes,
Yes,
even
ma'am.
the colonoscopy was not very favoring. It was not favoring an ulcerative colitis. The ulcers were also a little different.
Yes sir.
The mucosa didn't seem to be friable. So, can you show that colonoscopy finding? This one, it doesn't look like an UC, no?
Yes.
What was the colonoscopic diagnosis?
It's diffuse ulceration ma'am, with complete loss of vascularity, some mildly superficial which is excavated ulcer.
I mean, you expected to be more friable, more ulcerated, with blood and mucus in the lumen. To say, I mean, this, I don't, Dr. Ramakrishnan.
Maybe it's an
this is not
unprepared
present in this picture doesn't, it looks more like a cerebriform, something mucosa. Yeah, yeah, yeah. And that too for toxic. Yeah, yeah. He was not on any NSAIDs or anything.
No ma'am. No. He doesn't treated with any
No, the
anti-motility
thing is
drugs
like
also.
if supposing we were to do a colonoscopy and report on this,
Yes ma'am.
it's just colitis, but doesn't favor an ulcerative colitis.
It's
And-
colitis.
And even the frequency would be 20 to 30 times, you know, it's not 6 to 8 times in a severe ulcerative colitis. You won't get that frequency of just 6 to 8 with nocturnal disturbance.
Maybe treated with IV antibiotics and initially
No,
then.
no, ulcerative colitis per se, I'm saying.
Yes,
We're not talking of infective.
Yes.
Ulcerative colitis, just 6 to 8, blood and mucus, diarrhea. Is it any other infective cause that has been missed, like Salmonella or Campylobacter or Yersinia, one of those bloody diarrheas?
His blood culture was sterile ma'am. That doesn't.
Anyway, any other comments from the other?
Yes sir.
Is bowel settle down to a little?
Yes sir. Frequency of loose stool is 2 to 3
How
sir.
do you explain that?
Because of complicated by megacolon sir.
Because he had megacolon,
Yes, sir.
he is not passing stool.
Yes sir.
Okay. But no anti-motility drugs anywhere?
No, no,
I'm
sir.
saying.
He refer with mainly abdominal distension and pains. Yes ma'am.
Because the sigmoidoscopy is not consistent with the picture of ulcerative colitis. So still,
In the clinical picture, it's not fitting, no? 6 to 8 times, little blood and mucus in the stool.
we don't see any blood there.
You'll see 15,
The
20
ulcer.
times, there'll be so much of urgency, there'll be so much of
Very not very
frequency.
consistent.
I'm just wondering some of the rarer bacteria that has caused the infective colitis. Cultures were negative.
Yes ma'am. Culture.
C. diff, everything negative.
Yes ma'am. C difficile negative.
So what is Oxford criteria for acute severe ulcerative colitis?
Sir, stool frequency more than 6 per day with features of systemic, any one of the systemic signs such as tachycardia, fever, low hemoglobin and elevated inflammatory markers of CRP or ESR more than 45.
So what was his inflammatory markers?
Calprotectin was positive. CRP was
Sir, his inflammatory markers are normal, sir. I didn't put.
Normal.
Yes, sir.
Okay. Okay. So that again goes against probable acute ulcerative. What is this? So what is the proportion of patients who have acute severe ulcerative colitis who will have a normal ESR and CRP? Any literature evidence for a inflammatory marker negative? Even the platelet counts are not high.
Yes.
Well managed, but can you tell us what is the significance of low albumin in patients with ulcerative colitis?
Presence of low albumin which predict the infliximab failures, TNF alpha inhibitor failure. Generally they're more prone for infection also. And antibiotic.
Biologicals may also not be
Yes, sir.
very effective in that situation.
Good evening. There is a slight change in the order. The next case will be portopulmonary hypertension. Talk will be for 20 minutes by Dr. Arvind Manohar, Department of Medical Gastroenterology, Gleneagles Hospitals.
Good evening, everyone. I am Dr. Arvind from Gleneagles Hospital. I am doing first year gastroenterology. Today I am presenting a case of portopulmonary hypertension. This case was referred to Dr. Jayanti ma'am by Professor Dr. Rajinikanth sir, and this case was also presented at drills in August 2024. Patient is a 24-year-old female from Chennai working in an IT company, presented with exertional dyspnea for past 2 years. She was treated as a COPD patient with bronchodilators. She had a syncopal attack in August 9th, 2023. She had a history of low platelet count from the age of 12, but she never had any symptoms of liver cell failure or any family history of liver disease. And she is not married now, and she also had amenorrhea for 2 months. On examination, patient was moderately built with a BMI of 21 kg per meter square, pulse rate of 100 per minute, regular rate and rhythm, BP of 90-60 millimeter mercury, and saturation of 98% at room air. Patient also had malar flash and acneiform eruptions on the forehead. There was no clubbing or cyanosis, and there was no significant pallor, lymphadenopathy or pedal edema. And on systemic examination, patient was found to have grade 2 ejection systolic murmur in the pulmonary area with a P2 split. Her respiratory and CNS examination was normal. On per abdomen examination, she was found to have moderate splenomegaly. But the liver span was normal, and there was no visible veins or ascites, and hepatojugular reflex was negative. On investigation, she was found to have pancytopenia with a hemoglobin of 7.5, TC of 1200 and platelet of 40,000. She presented to us with all these investigation already done, and LFT, RFT, thyroid function, electrolytes were all normal, and ultrasound showed that she had normal liver parenchyma and normal portal vein with a diameter of 0.9 centimeter and splenomegaly with no ascites. On echo, there was finding of dilated right atrium and right ventricle with grade 2 tricuspid regurgitation, severe pulmonary artery hypertension with PASP of 140 millimeter mercury with a dilated main pulmonary artery and non-dilated pulmonary artery branches, and grade 2 pulmonary regurgitation. All these findings suggest that she had pulmonary hypertension, and there was suprasystemic pulmonary artery hypertension, which is pulmonary artery hypertension that is more than the systemic hypertension. And her X-ray showed that she had cardiomegaly, and main pulmonary artery and right and left branches were dilated, and HRCT chest was normal. As she had splenomegaly, we did a CECT abdomen. Liver was found to be slightly reduced in size, and there is caudate lobe hypertrophy, splenomegaly, and portal cavernoma, splenic artery aneurysm, and collaterals were found. And we came to a diagnosis of compensated chronic liver disease with portal cavernoma. Working up for CLD, we did a OGD which showed a small esophageal varices with mild PHG. On further workup, prothrombotic workup, copper studies, iron studies, viral serology, they were all negative, normal. And the autoimmune panel showed ANA positive, other autoantibodies were all negative. And fibroscan showed liver stiffness of 10.3, that is F3 fibrosis, and FIB4 score showed significant fibrosis. She also had undergone ventilation perfusion scintigraphy outside, and it showed low probability for pulmonary embolism. So, patient had portal hypertension with pulmonary artery hypertension. So, these could be the possibilities. What could be the diagnosis? As patient had CLD with portal hypertension and pulmonary artery hypertension, we came to a conclusion of portopulmonary hypertension.
This was one of the questions that is posed to the audience at the drills. So we just maintain that. So we give options, and anyway, okay, continue.
So, clinical classification of portal hypertension. There are 5 types. Type 1 is pulmonary artery hypertension. Type 2 is pulmonary hypertension associated with left heart failure. We ruled this out because of normal EF, and echo didn't show it. And pulmonary artery, third type is pulmonary hypertension associated with lung disease, and this was ruled out because of the chest CD was normal. And fourth type is pulmonary hypertension associated with any obstruction, pulmonary artery obstruction. This was also ruled out because her ventilation perfusion scan was normal. And fifth type is multifactorial causes. That was also ruled out in the workup of CLD. So we came to a conclusion of pulmonary arterial hypertension that is caused by any associated conditions, and her associated condition was CLD. And these are classification of drugs used for pulmonary artery hypertension. First class is prostacyclin derivative, that is selexipap, epoprostenol, ilioprost, and next class is endothelin receptor antagonist, that is ambrisentan, bosentan, macitentan, and PDE5 inhibitors like sildenafil and tadalafil, and guanylyl cyclase stimulators like riociguat. So, how do we manage suprasystemic portal artery hypertension? These are the following ways in which it can be managed. Either we can go for a protocol driven nitric oxide challenge test to channelize the medication, or we don't have to do the challenge test, and directly empirically we can start the PDE5 inhibitors and endothelin receptor antagonist, or we can do a right heart catheterization to confirm the diagnosis. So we consulted the pulmonologist, and we directly started the empirical PDE5 inhibitor and endothelin receptor antagonist. This is the nitric oxide challenge test, which is classified as either vasoreactive or non-vasoreactive. Vasoreactive is we give calcium channel blocker, and if there is any decrease, if there is decrease of mean pulmonary artery pressure of more than 10 millimeter mercury from the baseline to less than 40 millimeter mercury, without any decrease in cardiac output, that is vasoreactive. The other type is non-vasoreactive, that is further classified as with chest pain and syncope or without chest pain and syncope, and the treatment is as follows. Our patient had a WHO function class of 4, so we started the patient on all 3 classes of drugs, that is tadalafil, ambrisentan, and selexipag. Following the treatment, her breathlessness improved, and her repeat echo showed that pulmonary artery pressure has reduced to 120 millimeter mercury on peak systolic pressure. So we had a multidisciplinary team discussion with the cardiologist, pulmonologist, and hepatologist. The pulmonologist recommended that the patient undergo dual transplant with lung and liver. The pulmonologist suggested we have a discussion with the liver transplant team and reduce the pulmonary artery pressure to at least 35 millimeter mercury before she undergoes liver transplantation. So we consulted the cardiologist, who suggested that the patient undergo cardiac catheterization and then proceed for pulmonary artery denervation. There are few reports that suggest that pulmonary artery denervation can reduce pulmonary artery hypertension. As our patient didn't respond to medical treatment that much, her pulmonary artery pressure just reduced from 140 to 120. We thought we will go ahead with the right heart catheterization, and we measured the mean pulmonary artery pressure, pulmonary artery vascular resistance, pulmonary artery wedge pressure, and during the same procedure we also determined the pulmonary hypertension by measuring the HVPG, and during the same sitting we proceeded with pulmonary artery denervation. This is a catheter based procedure that uses radio frequency ablation, and it targets the baroreceptor reflex in the main pulmonary artery and its branches bifurcation. It reduces the sympathetic activity and in turn reduces the pulmonary hypertension. These are the indices. So our patient had pulmonary artery wedge pressure of less than 15. So it is a precapillary pulmonary hypertension with cardiac output normal, and as we discussed, patient was found to have pulmonary artery hypertension as the other etiologies were ruled out. This is the pulmonary angiogram, and we can see the pulmonary artery that is delineated in red. Pointer. Yes. This is the pulmonary artery that is delineated in the angiogram, and this is the pulmonary artery mapping that is done by the cardiologist, and the red spots are the areas with maximum PAP reduction. The other spots didn't have much reduction. The yellow spots had slight reduction. The red spots had the maximum amount of PAP reduction. Right heart catheterization. These are the values pre-procedure. The mean PAP was 70 mm mercury. Wedge pressure was 10 millimeter mercury, and vascular resistance was 12.6 wood units. Post procedure, the mean pulmonary artery pressure reduced to 60, and the vascular resistance reduced slightly from 12.6 to 11, and the wedge pressure did not show any improvement. So pulmonary artery denervation could be used as a bridge for transplant, for liver transplant, and the patient is currently doing fine for the past 2 months. We are waiting for the patient to come back for follow-up. The learning points are we can suspect portal pulmonary hypertension in patient with splenomegaly and pulmonary artery hypertension, and CCT should be done in patient with splenomegaly and hypersplenism even if the ultrasound is normal, and medical treatment is often associated with a poor response, and pulmonary artery denervation can be used along with the medical treatment who don't respond properly to medical treatment. Thank you.
Nice presentation. So, any literature on pulmonary artery denervation as a bridge to liver transplant?
So there are a few studies.
In India, they've done about 10 or 12 cases of pulmonary artery denervation. So it's a new technique. So this particular patient had no other option, and otherwise she's doing well. Her performance scale is actually 0. She's going to work and all that. But what's happening is, actually the case was referred as splenomegaly. We were about to send her to the hematologist. Then I just said, let's finish off with because she had hypersplenism, we did a CT. CT showed a portocarcinoma, And there's also splenic artery aneurysm. So the discussion at the Delhi forum was maybe that it's actually idiopathic pulmonary artery hypertension and the reverse is taking place and is affecting the liver. Okay, but we feel that the hypersplenism started at the age of 12 and the so-called breathlessness came on much, much later. So I still feel it's a POPH. Only 10 or 12 cases have been reported from India. And this was, at the time of presentation, we just did it before the submission. After that, the pressure came down by another 20. She's now 8th week, she's going to come for her next follow-up. We do not know, she's not decompensated as yet. The surgeons feel that the treatment for POPH would be a liver transplant. So,
I have a question
but they want
here.
the pressure to come down.
Sorry, I have a question. So this lady has a portal cavernoma.
Yes, sir.
Her liver functions are good. The liver stiffness is 10.7 kilopascals. Why do we suspect cirrhosis? So the thing is, it's well known that EHPVO can cause portopulmonary hypertension. And EHPVO can also cause liver lobe atrophy. On the CT, it looked as if the left lobe was a little bit atrophic.
Atrophy, yes, sir.
Yes. So it wasn't, see, normally what you get in cirrhosis is a left lobe hypertrophy, a right lobe atrophy, and remodeling. And here it's actually quite
Other way
from
around.
that. So the pattern is different. I'm asking, why do we even consider cirrhosis? Because if you say cirrhosis, then the treatment becomes liver transplant, and here there may be no indication for that.
The caudate lobe hypertrophy was there. That was the only thing that made us suspect. And in fact, I thought it was more like an NCI-PH. So, yeah, but not yet cirrhotic. It's not yet cirrhotic. Yeah, yeah. So I thought it was NCI-PH with a component of EHPVO and presentation of portopulmonary hypertension. But the people at the drill session, they said, no, it is idiopathic pulmonary artery hypertension. But biopsy we did not do. HVPG was high. Hepatic venous pressure gradient showed that she had a component of cirrhosis. It was 12. HVPG was 12. HVPG was 12, I think.
Yes, sir.
Yeah.
I think clearly a case of missed diagnosis. I think from childhood she's been having thrombocytopenia.
Thrombocytopenia.
So most probably I think it's been missed. But what is very surprising is that very high
Pulmonary artery pressure.
I've not seen
It's huge.
such high pressure.
Suprasystemic.
More than 140,
Yeah.
never seen.
That was also the comment. They've never seen that such high values. But I think what we learned from this was when nothing was available, we had some option of what's called we never knew about this pulmonary artery denervation. So I think that's a good option when drugs are not effective. Thank you.
Thank you.
We'll move on to the third case presentation.
The third case is short gut syndrome, not always intestinal transplant, by Dr. S. Hamsika from Rayla Institute of Medical Science.
Good evening, one and all. I would like to thank my department and TNISG for this opportunity. I will be talking on a child with short bowel syndrome and why not always intestinal transplant. Baby born on 13th of April in 2022 by elective LSCS with oligohydramnios plus breech presentation with a birth weight of 2.8 kg, cried immediately after birth. Child developed respiratory distress for which child required oxygen support. Started on infant formula through palliative feeds. Baby developed vomiting following these feeds, which was progressive, bilious and copious in amount and not bloodstained. On day 2 of life, X-ray and USG was suggestive of intestinal transplant, intestinal obstruction. CECT showed malrotation with midgut volvulus leading to intestinal obstruction. On day 3 of life, child underwent an emergency laparotomy, detorsion of bowel, Lath procedure, and excision of the gangrenous bowel, and an end-to-end anastomosis of jejunal junction. There was a patchy gangrenous small bowel noted, which was left in situ. On day 6 of life, baby underwent a redo laparotomy and excision of the remaining gangrenous bowel, and a stoma creation with the jejunal-ileal anastomosis. Baby was later shifted to a second hospital. The remaining length of the bowel was 16 centimeter with an intact ileocecal valve. In another hospital, baby was suspected to have a burst abdomen post-surgery. On day 11 of life, child underwent a laparotomy again with Platt's procedure and a small bowel resection and anastomosis with a double barrel stoma creation this time. There was 60% giveaway of the previous anastomosis with bile leak and adhesions in the small bowel, and the peritoneal cavity was also contaminated with bile and flakes with densely adherent bowel loops. Baby was started on TPN, and bowel opening was noted on post-op day 2. Child was started on neocate feeds. There was high stomal output and which was managed with ringer lactate and refeeds to the distal stoma. Post this, baby had multiple episodes of sepsis requiring IV antibiotics, and there were events of hemodynamic instability which required mechanical ventilation. On day 66 of life, baby was stable enough and underwent a laparotomy with stomal closure and anastomosis in view of the high stoma output and repeated bacterial fungal infections. Baby had 16 centimeter of small bowel with intact ileocecal valve. Parents were told to consult at our center for the option of intestinal transplant. At our center, we received a preterm baby with malrotation and small bowel gangrene with repeated laparotomies, extensive bowel resections, adhesion, sepsis, and fitting into short gut syndrome and intestinal failure. Intestinal status was 16 centimeter of small bowel with no stoma, ileocecal valve intact, and colon and upper GI tract intact. 2.5 kg was the admission weight. Abdomen on examination was soft, not distended, scar was present. Issues faced at our center. Baby had recurrent central line infection, hence we had to establish a Brovia catheter, appropriate central line care and antibiotic for treatment. Diarrhea, hydration with IV fluids, electrolyte correction, managed with loperamide, probiotics and octreotide. Then intestinal rehabilitation, glutamine supplementation, parenteral nutrition and hydrolyzed formulas were given. Prolonged TPN dependency, baby was monitored for intestinal failure associated liver disease, slowly tapering and establishing oral feeds. Escalation of feeds and parenteral nutrition at our center. So feeds were started on post-op day 7 at 1 ml every 6th hourly and gradually increased. Till the time child was on TPN, we had given SMOF, Cabivan, Peri, and the choice of formula was amino acid formula, Neocate. Bowel opening was 4 to 6 times every day. Feeds increased by 1 ml per hour every day, and parenteral nutrition was continued along with trace elements, and we were monitoring the LFT, lipid and electrolytes as per protocol. Child was discharged on home TPN. Neocate given secondarily as formula feeds. Weekly follow-up and weight monitoring was done. Gradually TPN was reduced and feeds were increased. Child had a few episodes of loose stools which were treated with oral antibiotics. There was one episode of blood in stool, and stool biofire had shown ET-EC growth and treated with antibiotics. Child was started on semi-solid at 8 months. Child was dependent on TPN till 7 months of life, and from 8th month was TPN free. Child was on probiotics and Creon. Now child is 2 years old on solid food, Incipro Gold, Pediasure feeds and cow's milk. Baby is on regular follow-up with good weight gain and growth. This is the series of events of the child. So started with bilious vomiting and progressive, which was progressive and copious on day 0. On day 2 of life, suspected of intestinal obstruction. Day 3, baby underwent an emergency laparotomy. On day 6, there was another redo laparotomy. This time there was a resection with 16 centimeter remaining bowel with an intact ileocecal valve. On day 9, baby was received in another hospital, and because of suspecting burst abdomen with anastomotic leak, underwent a laparotomy with resectional anastomosis. And and during this period, baby had multiple episodes of sepsis requiring antibiotics and ICU care. On day 66, baby underwent a laparotomy and stomal closure. And this is the last laparotomy, which had 16 centimeter of bowel and intact ileocecal valve and colon. At our center, we received the baby who was on TPN support with Neocate NG feeds. We were able to establish oral feeds of, on day 124, and there were multiple central line associated infections, so another central line was secured and baby was discharged on oral feeds and home TPN. So baby, we received the baby at 4th month of life, and there was a slow and steady weight gain, and now baby is appropriate for age. So definition of intestinal failure: it's a reduction in the functioning gut mass below the minimal amount necessary for the adequate digestion and absorption of nutrients. A critical reduction of the gut mass or its function below the minimum needed to absorb the nutrients and fluids required for the adequate growth in a child minimum of 60 days. So there are 3 types. Type 1, common, temporary and post-abdominal surgery requiring short-term fluid or nutritional support. Type 2, less common, post-surgical resection associated with metabolic or septic complication requiring long-term nutritional support for recovery, but may develop into type 3 if poorly managed. Type 3 is rare, chronic, and requires long-term or home TPN support and may also be treated with intestinal lengthening procedures or intestinal transplant. Intestinal rehabilitation is the process of optimizing the bowel function through diet modification, pharmacological therapy, and surgical intervention to aid in the nutritional autonomy and independence from the parental nutrition. The predictable factors for native intestinal adaptation are resection at a younger age has a higher potential for small intestinal adaptation and growth, physiological process of the intestinal adaptation stimulated by the endogenous and exogenous factors. So in this baby, how we escalated feeds were, we initially, baby was started on formula feeds, so we chose a hydrolyzed formula. Then we watched for the tolerance and the stool output. Initially baby had diarrhea, a higher stool output, so we slowly went up on the feeds. So once the stool output was less than 20 to 50 ml per kg per day or 6 to 10 stools per day, we slowly increase the feeds every 1 to 3 days. If the stool output is still high, we need to hold or reduce the feeds 1 to 3 days and watch for the better tolerance or stool output. So the advantages and disadvantages: human milk has the best advantage. Immunoglobulins are present, prebiotic substrates, bioactive proteins and growth factors. Polymeric formula will have higher LCT, but there is risk of allergy. Extensively hydrolyzed formula, there is absence of lactose and higher MCT, but again there is a low energy content and lower LCT. Amino acid is, if you are suspecting cow milk protein allergy, then amino acid formulas can be used. Evidence of stomal refeed: mucosal fistula refeeding is a treatment for the intestinal failure and short bowel syndrome that involves instilling proximal ostomy contents into the distal enterostomy or mucous fistula. It can help with the nutrient absorption, prevent atrophy of the unused distal bowel, weight gain, and reduce the dependence on the total parental nutrition. Teduglutide is an agent which is used to promote the intestinal mucosal hypertrophy, inhibits the gastric motility and acid secretion, improves intestinal blood flow, increases the intestinal barrier function, and enhances the nutrient and fluid absorption. Indication is short bowel syndrome with intestinal failure, fully dependent on the parental nutrition, as well as in some children partially dependent. Prior to use, we need to exclude intestinal obstruction and negative fecal occult blood, and age more than 10 years, we need to investigate for intestinal polyps. Given in more than 12 months of age and more than 10 kgs, dose 0.05 mg per kg per day in a metabolically stable child with short bowel syndrome, intestinal failure. Adverse effects are mostly GI effects: vomiting, diarrhea, abdominal pain and stomach complication, pyrexia, cough and headache. So these are the indications for parental nutrition, and we used it for short bowel syndrome, and the baby had extensive resections. So weaning off TPN. Parental nutrition weaning is normally defined as the gradual reduction of the parental nutrition calories needed by the child while maintaining optimal growth velocity. Parental nutrition weaning should only be considered if the child with short bowel syndrome is showing appropriate growth. Early parental weaning, which is less than 2 years, should be proposed and attempted by intestinal failure rehabilitation caring physicians for infants more than 20 centimeter of residual short bowel and presence of the ileocecal valve. Parental nutrition weaning in appropriate settings may be attempted where the small intestine is less than 20 centimeter or 10% and presence of ileocecal valve, because this gives 50% of the success rate. In case of success, tight follow-up after weaning is mandatory. When attempting to wean from parental nutrition, regular follow-up should be intensified to identify signs of nutrient malabsorption. So these are the indications for small bowel transplant. Failure of parental nutrition. Parental nutrition induced liver injury. Any impending liver failure, bilirubin above 3 to 6 milligram per deciliter, progressive thrombocytopenia and progressive splenomegaly, overt liver failure like portal hypertension, hepatosplenomegaly and cirrhosis. Central venous access device related to thrombosis, 2 or more central veins. Frequent central vein infection, which is 2 episodes per year of systemic bacteremia requiring hospitalization, single episode of line-related fungemia, septic shock and or acute respiratory distress syndrome, frequent episodes of severe dehydration despite IV fluid in addition to parental nutrition. Here, the high risk of death attributable to the underlying disease like tumors, desmoid tumors associated with the FAP, congenital mucous disorders and ultra short bowel syndrome. Gastrostomy, duodenostomy or the residual small bowel, 10 centimeter infants and 20 centimeter in adults. Intestinal failure with high mortality and low acceptance of parental nutrition. So intestinal failure with high morbidity or inability to function, frequent hospitalization, narcotic dependency, pseudo-obstruction and high output stoma, and if the patient unwillingness to accept long-term parental nutrition. Criteria for living donor intestinal transplant. So from an adult to a baby should weigh at least 9 to 10 kg. So this again shows the importance of intestinal nutritional rehabilitation. In conclusion, feeds should be titrated according to the patient and on day-to-day basis with utmost care, and the management is multidisciplinary. Thank you.
Thank you, doctor. Thank you for highlighting such an important case and showing the resilience of an infantile small bowel. I'll open questions from the house. Madam.
What was the cost of the treatment? Total cost for the treatment?
Baby required hospitalization for seven months, madam, and at least in 4 different hospitals, and most of them were private.
So the problem is the affordability that you should understand.
Okay.
It's very difficult to manage. Even home parental is very, very difficult.
Baby is doing
Yes,
well
baby.
now, sir. Coming for regular follow-up for vaccination.
This child has got a lot of good things, because the child is, it's only a malnutrition which is gone in for a gangrene. It's not a the intestines are as such normal, and the child had an intact IC valve and 20 centimeters left behind. So that's why this child had all favorable factors. But there are children without favorable factors where we cannot manage by this alone. That also you should highlight, no? That also you should highlight.
Sure.
What are the favorable factors in this child?
I think the presence of the colon was the advantage in this patient. It acts as a salvage organ. Colon is the salvage organ. And we have an ileocecal valve. The terminal ileum takes the jejunization. It takes the function of the small bowel. If you take a biopsy of the terminal ileum, it will be like a jejunum. So I think the child had a favorable anatomical, whatever was left behind. Why was creon given for this patient?
Which one?
Creon. You had mentioned creon.
Pancreatic
Pancreas
insufficiency.
is normal.
When jejunum is...
No, you don't need creon. Patient does not have child does not have malabsorption.
Good presentation. Why the child was not well breastfeeding on day 1? Because the problem is that can itself produce an NNAC picture to the advice. Presenting with bilious vomiting, diarrhea, abdominal distension, almost mimicking a surgical condition. They can present dyslipidemia, dehydration, shock, all those features. Maybe concomitant to your malnutrition, whatever it is. So, but the factors, what are there, madam has said, they are there, and early intervention has helped this child. Otherwise, child would have gone in for growth.
Yes,
that's very important. As madam said, if the child is on breastfeeding, it contains pre-emulsified fat, doesn't require your creon, whatever it is. Because that's a thing.
Yes, ma'am. Baby had, when the baby came, baby was malnourished, had diarrhea, ma'am, high stool output. So we were thinking of maybe CMPI, other factors. So we chose
The breastfeeding is stopped, is it?
Probably
Never-
breastfeeding must not have been established
Not
because the child
established,
was
no.
sick.
Yeah, but
The child
subsequently-
was referred to 66 days.
Subsequently?
No, ma'am. Dependent on TP and no, it was
So
not
they could have
established.
maintained it if they want. Express and they could have maintained it, but they've not done it.
As you said, the first line of feed is mother's breast milk, then followed by next hydrolyzed formulas. So short-gut syndrome also has multiple other complications like micronutrient as well as macronutrient deficiencies. How were they addressed in your case? Were they addressed? Because a lot of small bowel has gone. Only 16 centimeter of small bowel is still present. As you know, lots of micronutrient as well as macronutrient absorption happens in the proximal bowel as well as some in the jejunum. So were they addressed?
Yes, sir. Along with the TPN, we gave multivitamins and minerals, trace elements.
Out of ignorance, I'm just asking it. As the child grows, is that 16 centimeter, 20 centimeter, won't that also increase? I mean, does it help? Like in an adult, if we lose, they say 2 meters or 3 meters of intestine, there is no way that it is going to grow back, isn't it? But in a child, even though the residual intestine length was like 20 centimeters or whatever, does it also increase to a normal length, or how does it work?
I don't think the length increases, the function improves. As far as
It
I
remains only 20 centimeters, I mean, when the child grows?
That's
It will grow. Because the adult, it doesn't reach adult size by 1 year. It takes time. So it will definitely grow. Definitely big. But I don't know. Adult size it cannot become, but definitely grow. But we don't know how long it's going to grow, that we don't know, but definitely it will grow.
If there are no further questions, I think we can close the case.
Thank you.
Thank you, Doctor. I call upon Dr. Nimish Jacob for his review of literature on Wilson's. And it is indeed a privilege to present this in front of persons who have contributed so much to the literature of Wilson.
Good evening, respected teachers and my dear friends. I am Dr. Nimish Jacob, final year resident from the Department of Digestive Health and Diseases, Kilpauk Medical College. I would like to thank the Tamil Nadu Society of Gastroenterology and my guide, Dr. Mallory ma'am, for providing me an opportunity to present today's review of Indian literature on Wilson's disease. I'll be discussing the topic under the following headings. We'll be having a brief outlook regarding the history of the disease, followed by epidemiology, genetics, pathogenesis, clinical features, investigations and management, disease monitoring, bedside challenges we can face, and take-home message. So as we know, Wilson's disease is an inherited autosomal recessive disorder of copper metabolism due to mutation in the ATP7B gene, leading to copper deposition in various organs, primarily the liver and brain. The first description of Wilson's disease was made by Dr. S.A. Kinnear Wilson in the Brain Journal in the year 1912. It was actually his MD thesis, and he was awarded the gold medal for his thesis submission by the Edinburgh University. So he described the disease in 1912 as a familial disease characterized by progressive lenticular degeneration with liver cirrhosis and a corneal abnormality. The initial drug which was used for the treatment of Wilson's disease was British anti-leucite, which had a whole lot of side effects. In the year 1956, Dr. Walsh had reported the success of penicillamine, which is a drug which is commonly used nowadays in the treatment of Wilson's disease. And in the year 1969, Dr. Walsh himself introduced trientine to treat Wilson's disease patients in those who developed penicillamine-induced nephropathy. And in India, the first case series of Wilson's disease was made almost 50 years later in the year 1963 by Dr. Wadi and Dr. Dastur. So these are the famous personalities: Dr. S.A. Kinnear Wilson, Dr. John Walsh, and Dr. Wadi and Dr. Dastur. Now coming to the epidemiology of Wilson's disease, in a study by Dr. Prashant et al. Published in the Journal of Neurology, Neurosurgery and Psychiatry in the year 2004, India has been described as one of the geographical hotspots of Wilson's disease. Wilson's disease occurs worldwide with an estimated prevalence of 1 in 10,000 to 1 in 30,000, but the frequency in India is perhaps more frequent because the disease is more common where consanguinity is prevalent. In a study from Chandigarh between the years 1991 and 2000, out of 517 children with portal hypertension, 203 had cirrhosis, and the most common etiology being Indian childhood cirrhosis followed by Wilson's disease in 7% of population. And in a study from Vellore between the years 2000 and 2007, Wilson's disease was the predominant cause of cirrhosis, leading to portal hypertension in 55% of pediatric population. And the gene frequency is 1 in 90, that is 1 out of every 90 to 90 persons carry the gene for Wilson's disease. And we have observed a significant male predominance in the Indian series with a male to female ratio of 2.7:1. In a study by Dr. M. Patil et al. From St. John's Medical College published in the year 2013, they had reported approximately 15 to 20 new cases being diagnosed every year in their center, with more than 2/3 presenting with primarily liver-related complaints, with a considerable number presenting with acute liver failure. So Wilson's disease is a masquerader with a great variability in the age of onset and symptom manifestations. The usual age group is 3 to 50 years of age, though there are rare case reports of Wilson's disease in those less than 3 years and those over the age of 50 years. In the year 1992, Dr. Walsh and Dr. Yelland had described an age phenotypic correlation in the presentation of Wilson's disease. In their study, they concluded that children less than 10 years of age more often presented with hepatic disease, whereas those over the age of 18 years of age presented more commonly with neurological or psychiatric manifestations with or without chronic liver disease. So an age phenotypic presentation was described by Dr. Walsh and Dr. Yelland in the year 1992. Now coming to the genetics of Wilson's disease, the ATP7B gene is located on the long arm of chromosome 13. It has 21 exons. The mutations can be either homozygous or compound heterozygotes. More than 750 mutations in the ATP7B gene have been described until date, the majority being missense, nonsense or frameshift mutation. The most common mutation is H1069Q in the western part of the world, whereas in East Asia, the most common mutation is R778L. But when you have a look at the genetics from the Indian scenario, both the above mentioned mutations which are seen in the western and the eastern part of the world are almost non-existent in India. In India, we have a wide spectrum of mutations despite having a high rate of consanguinity, and that is called the Indian paradox. And in India, we have a higher degree of homozygosity, up to 60% being reported in the various studies, mostly due to the intra-ethnic, intra-caste marriages and consanguinity. So in a study by Dr. Santosh et al. From CMC Vellore in the year 2006, they tried to analyze ATP7B gene mutations in 27 Wilson's disease patients from the southern states of Tamil Nadu, Kerala and Andhra Pradesh. And out of the 27 patients, 11 new mutations were described in this paper, and the two most common mutations being G31A2A in 16% and C813A in 12% of population. And the hotspots for ATP7B gene were exons 18 and 13. In another study by Dr. S. Kumar et al. Published in the year 2005, the study was done in Chandigarh in 43 patients from northwest India, in which 18 new mutations were identified, and the most common mutations being T3305C, C2975A, and 29977A. And exons 8, 12, 13, 15, 16, and 18 were considered to be the hotspots for mutation. And in another study by Dr. Gupta et al. From Kolkata in the year 2005, in which 200 individuals were studied and 5 new mutations were described, and the most common mutation in their study was C813A. In another study by Dr. Suresh Kumar et al. Published in the Indian Journal of Gastroenterology in the year 2012, they concluded that the common mutations which were described in the western and the eastern part of the world were lacking in India, and they quoted the previous 3 studies which we have mentioned from Vellore, Kolkata and Chandigarh with the commonest mutations which were seen in those 3 studies. And they also identified consanguinity in 44% of patients with Wilson's disease. In another study by Dr. Anu Agarwal et al. In the year 2013 from Mumbai, they studied, the 52 patients were studied and 14 new mutations were identified, and in this paper they concluded that PC271 was the most common mutation in India, followed by PE122 frameshift mutation. And this paper reported high degree of homozygosity up to 60% in the Indian population, and compared to the European Wilson's disease cases with H1069Q, which usually present in the second and third decade with primarily neurological features, the commonly detected variant in India as per their study, which was the PC271, present more earlier in the first and second decade with very severe clinical manifestations. So basically the aim of all these studies was to find out a genotypic phenotypic correlation, that is why the ATP7B gene, why the same ATP7B gene mutation caused hepatic Wilson in some patients and neuro Wilson in other patients. So that was the main aim of studying of these genetic studies. And in another study by Dr. Santosh et al. In the year 2008, in which they tried to identify, they tried to study 9 documented cases of Wilson's disease from 4 unrelated families from Tamil Nadu and Andhra Pradesh. 4 separate mutations were found in the 4 families, but in this study they identified identical mutations within each family. And 3 mutations were novel mutations, which were A2623G, G4021A, and A3029G. And this study noted concordance between the ATP7B genotype and phenotype amongst the members within each family. But the sample size was just 9 patients. In another study by Dr. Arun Tali et al. From NIMHANS, they had concluded that nearly half the Indian cases had a positive family history, and there was a mean diagnostic delay of 16 to 28 months in the Indian cases, mainly due to the illiteracy, poverty, and due to the lack of adequate medical facilities. Now, coming to why the pathogenesis on why we get Wilson's disease, copper, as we know, is an essential trace element which is an important cofactor for many enzymes involved in cellular respiration, ion oxidation, pigment formation, neurotransmitter biosynthesis, antioxidant defense, and connective tissue formation. And the recommended dietary allowance is 0.9 milligram, and the major route of copper elimination is by biliary excretion. Hence, liver plays a critical role in the metabolism. So, out of the total oral intake of copper in our diet, 25 to 40% of copper gets absorbed. The rest gets unabsorbed and gets excreted by the fecus. And the absorption of copper mainly takes place in the duodenum and the proximal jejunum via the copper transporter receptor 1 and the divalent metal transporter 1 genes. And if there's a defect in this absorption, we get the Menkes disease, in which there is copper deficiency. So, once it gets absorbed into the enterocyte, it binds to proteins like albumin and goes via portal circulation into the liver. And once it reaches the liver, it enters into the hepatocyte via copper transporter receptor 1. Inside the hepatocyte, we have metallochaperones and metallothioneins. Metallochaperones are mainly involved for transport within the cell, whereas metallothionein is involved in storage of copper. So one such metallochaperone is ATOX1, antioxidant 1, which carries the copper to an ATP7B protein. This ATP7B protein has dual functions. It is involved in maintaining the copper homeostasis in our body. So when the copper levels in our body is less, this ATP7B will incorporate the copper into apocelluloplasmin to form celluloplasmin, and this celluloplasmin goes to the cells for various cellular functions. Whereas if the copper is excess in our body, this ATP7B protein will promote the excretion of copper into the biliary canalicus. So ATP7B is the major controller for the copper homeostasis in our body. So in Wilson's disease, when the ATP7B gene gets mutated, what happens is that the copper cannot be excreted into the biliary canalicus, as well as the copper will not get incorporated into apocelluloplasmin to form celluloplasmin. As a result, copper gets deposited in the hepatocyte and other tissues. Now coming to the clinical features, hepatic presentation. Any hepatic presentation can be a presentation of Wilson's disease. Anyone with an asymptomatic hepatomegaly, anyone with a fatty liver detected incidentally on ultrasound, or anyone with persistent transaminitis, anyone who presents with acute hepatitis, chronic hepatitis may turn out to be a case of Wilson's disease. So we should have a high index of suspicion. The most common presentation from the Indian series was cirrhosis and its complication. They can also present with acute liver failure and acute and chronic liver failure. They can also present with cholelithiasis due to the hemolysis, and HCC is comparatively rare in Wilson's compared to other causes of cirrhosis. Coming to neuropsychiatric manifestations, mainly we get extrapyramidal symptoms. The most common symptom is dysarthria in 93% in the Indian series. But unfortunately, dysarthria is a symptom which responds last and the least to medical treatment. We might get coarse irregular tremors. The classically described wing beating tremors may be seen, dystonia may be seen, Parkinsonism-like features may be seen, gait disturbances may be seen. We can see sometimes we may see the Wilson's species, which is described as a vacuous smile with an open mouth, hypersalivation, and a dull look. We can have personality changes, psychotic behavior. Since this disease is more common in the adolescent age group, these personality changes and psychotic behaviors are usually attributed to the behavioral changes in adolescence, and often the diagnosis gets delayed. So you have to always keep in mind about Wilson's also when you encounter such cases in clinical practice. They can have mild cognitive impairment and poor scholastic performance also. Musculoskeletal manifestations include osteoporosis, osteomalacia, arthralgia, and arthritis. Hematological manifestations include Coombs nectar, hemolytic anemia, thrombocytopenia, and pancytopenia. Ocular manifestations include KF ring, which is due to the copper deposition in the Descemet's membrane of cornea, and sunflower cataract due to the deposition of copper in the lens. We can have renal manifestations like tubular injury, renal tubular acidosis, and glomerulonephritis. Endocrinal manifestations include amenorrhea, testicular atrophy, pancreatic inception, and hypoparathyroidism. And cardiovascular manifestations include cardiomyopathies and conduction abnormalities. So this is the classical KF ring. This is the classical vacuous smile seen in Wilson's disease, and this is the classical wing beating tremor seen in Wilson's. So in a study by Dr. Sanjay Kumar et al. Published in the Indian Journal of Gastroenterology in the year 2024, in which they tried to find out a clinical profile of the adult and pediatric patients presenting with hepatic Wilson's disease. It was basically a single-center retrospective study by collecting database between the years December 2006 and January 2021, in which they studied 140 patients. 88 were adults and 52 were children, and the median age of presentation was 17 years, and both the adults as well as the children pediatric population had a male predominance, and the most common presentation in adults was cirrhosis and its complication, and the most common presentation in children was acute and chronic liver failure. And in those children who presented with acute and chronic liver failure, the 28-day mortality was around 50%. So the median age of presentation was 17 years with a male predominance, and the most common presentation in adults was cirrhosis and its complication, and pediatric population was acute and chronic liver failure. And the most common presenting complaint was jaundice followed by abdominal distension followed by the complications of portal hypertension. And in another study by Dr. Vajpayee et al. From SMS Jaipur, published in the year 2024, in which they tried to find out a clinical profile of Wilson's disease children from western part of India. They studied 50 patients, 38 of them presented with hepatic Wilson's, and 12 of them presented with neuropsychiatric manifestations. And the mean age was lesser in the hepatic presentation than the neuropsychiatric manifestation. The mean age of hepatic presentation was 7.5 years, whereas those who presented with neuropsychiatric manifestation had a mean age of 10.5 years. And the most common hepatic presentation was chronic liver disease, and the most common neuropsychiatric manifestation in this study was chorioathletic movements. And the presenting complaint was jaundice, abdominal distension, and complications of portal hypertension. In the initial case series reports by Dr. Wadi and Dr. Dastur had osteomuscular manifestations also, but in the later studies we had more of hepatic and neuropsychiatric manifestations. And in the study by Dr. Kapoor et al. From CMC Vellore, published in the year 2017, they found out renal tubular acidosis in more than half of the patients presenting with Wilson's disease, and they found out that this renal tubular acidosis was more common in hepatic Wilson's disease, which had a longer disease duration, and it usually manifests with metabolic bone disease. So this is a part which we often neglect. Whenever we hear of the term Wilson's disease, we always think about the hepatic and the neuropsychiatric part. We have to always evaluate and work up for the renal part, and also check whether the patient is having renal tubular acidosis also, because it may lead to metabolic bone disease like osteomalacia and rickets, which can lead to a lot of morbidity in the adulthood. So always take care of the renal part also when you're dealing with a case of Wilson's disease. In a study by Dr. Bhupendra Kumar Bajaj et al. From Delhi, they found out cardiomyopathies, cardiac arrhythmias, and autonomic dysfunctions were also reported in patients with Wilson's disease. And in another study by Dr. Meenakshi Sundaram et al. From NIMHANS, they reported ECG abnormalities in up to 30% of cases with Wilson's disease, mainly due to the cardiac copper deposition. Now moving to the investigations, we'll start off with the baseline LFT, followed by the three most important investigations, that is serum ceruloplasmin, 24-hour urinary copper, and the ophthalmic evaluation for KF ring. And to support our diagnosis, we can do a genetic testing with the liver biopsy. So ceruloplasmin, as we know, is an acute phase reactant. It's a protein synthesized in the liver. Low serum ceruloplasmin has been reported in 85 to 95% of Indian cases, and we can measure ceruloplasmin by the enzymatic or immunological method. We prefer the enzymatic method over the immunological method because immunological methods can overestimate the levels of ceruloplasmin. And the lower the ceruloplasmin value, the more likely we are dealing with Wilson's disease. So the normal value of ceruloplasmin is 20 to 40. Values of less than 10 or less than 5 are strongly in favor of Wilson's disease, whereas the values between 10 to 20 may be seen in 20% of heterozygote patients also. And normal values may be seen in acute inflammatory, when the patient presents with acute inflammatory conditions like acute liver failure and acute and chronic liver failure. So 1/3 of the cases may have a normal ceruloplasmin level also. Falsely low ceruloplasmin values may be seen in when the patient is having a marked renal or enteric protein loss in end-stage liver disease, and on those in prolonged parenteral nutrition and in Menkes disease. And falsely high values may be seen in acute inflammatory states and hyperestringent conditions like pregnancy and OCP use. Now coming to 24-hour urinary copper, which reflects the amount of non-ceruloplasmin bound copper in circulation. In untreated symptomatic patients, a value of more than 100 microgram over 24 hours is almost diagnostic of Wilson's disease, and 70 to 100% of Indian Wilson's disease cases have a urinary copper excretion of more than 100 microgram over 24 hours. And in children and asymptomatic patients, we can lower the cutoff to more than 40 microgram per over 24 hours to increase the sensitivity of the copper estimation. And falsely low values can be seen when there is an incomplete collection and in those children without liver disease, and high values may be seen when there is hepatocellular necrosis due to some etiology in cholestatic conditions, and when there is a contamination from the container used for collection. And the D-penicillamine challenge test is now gone out of favor because of the high false positive rates. In this test, what they used to do was collect a baseline 24-hour urine sample followed by giving penicillamine for 500 milligram BD for 1 day, followed by next 24 hours urinary collection, and a value of more than 1575 microgram over 24 hours was considered to be diagnostic, but now this test has gone out of favor. Now coming to liver biopsy and hepatic copper stains, on liver biopsy, the findings which we get are actually non-specific. We can get steatosis, we can get hepatocyte ballooning, interface hepatitis, glycogenated nuclei, and periportal copper deposition. And to increase the yield, we can use copper-specific strains like orcine, rhodinin, and rubionic acid. Also, we can also do a hepatic copper estimation in which a value of more than 250 microgram per gram of dry weight is considered to be diagnostic of Wilson's disease. But the yield of biopsy is less, so mainly we'll prefer the other three: ceruloplasmin, urinary copper levels, and KF ring. Now coming to genetic testing. Genetic testing is mainly done nowadays only in two settings. One is for screening of asymptomatic siblings of index patient, and one is to confirm the diagnosis, because if our the ceruloplasmin levels 24-hour urine copper values are inconclusive, to confirm the diagnosis we can use genetic testing, because confirming the diagnosis is very, very important, because we are subjecting the patient to lifelong chelation therapy, which has a lot of side effects also. So we should always confirm the diagnosis before starting treatment, and also if you delay the diagnosis, it can lead to a lot of morbidity and mortality in the future. So for confirming diagnosis, we can use genetic testing. Genetic testing is done only in very few centers in India, and we can do genetic testing by two methods. One is by screening for mutations in all the 21 exons, which is an expensive and daunting task, or we can do a next generation sequencing, a PCR based analysis. And this a study from CMC Vellore has been done on the PCR based next generation sequencing method for genetic testing, and the results have been promising. So it's an upcoming test. Now coming to the MRI brain, for neurovilsons, we can see the classical face of giant panda sign, in which we have a hypointense red nucleus followed by the ductal plate hyperintensity. We can have central pontine myelinosis like abnormalities, signal changes in the basal ganglia, thalamus and brainstem, and cortical atrophy and ventricular dilatations may be seen. So a triad of KF ring, a 24-hour urine copper of more than 40, and serum ceruloplasmin levels of less than 20 suggestive of Wilson's disease. And to contribute, we can use genetic testing, liver histology, and family history. This is another upcoming test which is coming up, that is a level of exchangeable copper, that is a copper which is not bound to ceruloplasmin, that is the copper which is present in serum as free copper and bound to albumin and other peptides. So the levels of exchangeable copper and the levels of relative exchangeable copper, which is the ratio of exchangeable copper to the total serum copper. These two levels in Western studies are found to be higher in non-survivors when compared to survivors. So these levels can be used to prognosticate the patients and also for assessing the chelation adequacy. Now coming to family screening, mainly we'll screen the first degree relatives, that is the parents, siblings and offsprings, and screening should be done after the age of 2 years unless they have any features of liver disease prior to it, and we'll do with the baseline LFT, KF ring, ceruloplasmin and 24-hour urinary copper, and if any doubt is there, we can move forward for genetic testing. And family screening has two main purposes. One is it helps to identify, it helps in early detection of the disease in the pre-symptomatic phase only, and also it helps to identify the healthy family member who can be a potential donor for liver transplantation if the patient presents with acute liver failure. Now coming to the management guidelines, we have various guidelines put forward for management for Wilson's disease. We have the ASL guidelines, which was published in 2012. We have the European Society of Pediatric Gastroenterology, Hepatology and Nutrition guidelines published in the year 2018, and we have the ASLD guidelines, which was published recently in 2022. And in India, we have the guidelines which was put forward by three societies, that is by the INASL, by the Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition, and by the Movement Disorders Society of India. So all these three societies together put forward the Indian guidelines. Most of these guidelines, EASL, ESPGHN and ASLD and the Indian guidelines are almost similar with minor changes here and there. So coming to the Indian guide, in the original EASL guidelines published in 2012, we had the Leipzig scoring system, in which the parameters include KF ring, neurological symptoms, serum ceruloplasmin levels, Coombs negative hemolytic anemia, liver copper levels, urinary copper levels, and mutation analysis. And a value of more than 4 was considered to be diagnostic of Wilson's disease. But in the Indian consensus, they modified this Leipzig score, and they validated that score in 70 patients with proven Wilson's disease, and it was found to be better in Indian population compared to the original Leipzig score. And the modified Leipzig score of more than 4 was diagnostic. The difference in modified Leipzig score was that extra weightage was given to ceruloplasmin values less than 5, and extra weightage is given to family history, and liver copper estimation was taken out of the equation. So value of more than 4 established the diagnosis, and the 3 changes which was made was: one is extra weightage given to ceruloplasmin levels less than 5, additional points given for family history, and liver copper estimation was omitted because of methodical flows and non-easy availability. Now coming to the treatment of Wilson's disease, we have the medical management using chelators like D-penicillamine, triandin and ammonium tetrathiomolybdenate, and we can use zinc, liver transplantation in the case of acute liver failure, and others include dietary restriction of copper-rich food items like shellfish, nuts, chocolates, management of cirrhosis and its complications. So penicillamine is the drug which is most commonly available. We have maximum evidence available. It's cheap also. A month treatment of penicillamine costs less than 2,000 rupees. So as of now, in the Indian scenario, it is a primary drug for the management of hepatic Wilson's disease, and it mainly acts via chelation and excretes excess copper in the body via the urine. The dose is 250 to 500 milligram per day.
Nimish, for want of time, you can.
Okay. Is given in 2 to 4 divided doses, and food interferes with absorption, hence you have to give it either 1 hour before or 2 hours after meals, and you have to always supplement pyridoxine because penicillamine can cause inhibition of pyridoxine kinase enzyme, and we get a delayed response, and due to the sudden mobilization of copper from the tissues, we can have a paradoxical neurological worsening, and it has been reported in 30 to 33% of Indian cases. And adverse effects include fever, skin rash, bone marrow suppression, kidney proteinuria, and neuromuscular manifestations like myasthenia gravis and polymyositis. Now coming to trientine, trientine is a chelator with fewer adverse effects compared to penicillamine, but it is more expensive. A month's treatment can cost around 10,000, 12,000 per month, and it's also given either 1 hour before or 3 hours after meal, and it's mainly used in Indian scenario. It is being used in patients who are intolerant to penicillamine, and in those who are having very severe thrombocytopenia due to hypersplenism like 20,000 to 30,000 counts, or those who are having significant renal disease in which we can't start penicillamine as the first line drugs. And recent Western study literature shows it can be used as a first line drug over penicillamine. And coming to zinc, zinc will interfere with the uptake of copper from intestine and also induces enterocyte methylmethionine, and we can use sulfate, gluconate or acetate salts. 150 milligram per day is given as 3 divided doses. It's mainly used only as a maintenance therapy after the initial decoppering phase and in asymptomatic patients who are detected by screening. And ammonium tetrathiomolybdenate is a very strong decoppering agent. It's not available in India, but the advantage is that it has less neurological deterioration. Comparing penicillamine and trientine, in the Western studies, they have found out that both of them are equally efficacious in neuro-Wilson as well as hepatic Wilson. But when those patients are followed up for a year of 13 years, they found out that there were more side effects associated with penicillamine, leading to drug discontinuation in around 28% of patients compared to trientine. And in acute liver failure, we have two ratios which was put forward in a paper by Berman et al., in which he suggested that a ratio of ALP bar bilirubin less than 4 and a ratio of AST bar ALT of more than 2.2 was 100% sensitive and specific for predicting Wilson's disease. And in those who are having encephalopathy, you have to move forward with urgent liver transplantation, and those without encephalopathy, we can take the decision based on the individual case-based approach. And we can rapidly remove copper by using MARS or therapeutic plasma exchange, which is found to be beneficial and can be a bridge to liver transplantation. And in clinical practice, for prognosticating whether the patient needs medical therapy or liver transplantation, we can use a NASA's prognostic index, in which we have bilirubin, SGOT, and prothrombin time, each graded from a score of 0 to 4. A score of less than 7 can be managed with medical therapy. Score of more than 9 can be considered for liver transplantation. Between 7 to 9, we can use our clinical judgment to decide on the treatment. And in another study by Dr. Anil Dhawan et al., he put forward a new scoring system called New Wilson Index, in which bilirubin is there, SCOT is there with INR instead of prothrombin, and he included WBC count and albumin also, and a value of more than 11 indicates that the patient will.
Nimish, you can go to the conclusions. Concluding slide, you can go for the conclusion.
Okay. Liver transplantation has found to be beneficial in a study from Medanta, and plasma exchange also has been found in a study from ILBS. Plasma exchange also has been found to be not only as a bridge to liver transplantation, but it also improves the proportion of cases without transplant also. And for disease monitoring, mainly we use urinary copper levels and serum free copper levels. And the challenges we faced while we are treating the patient in clinical practice include: one is the diagnosis is made with a constellation of clinical laboratory parameters, and which can overlap with other liver diseases as well, and there is a lack of genetic testing facilities, and the availability and the affordability of chelators along with their side effects can lead to a drug discontinuation in a majority of patients. And to distinguish between the complication of the disease per se and the adverse effect of chelators is a challenge when you're treating in day-to-day clinical practice, because if the patient is having pancytopenia, it can be due to the hypersplenism, or it can be due to the adverse effect of the chelator drug also. So to distinguish between such complications is a challenge when you're treating the patient in day-to-day clinical practice. So the challenges we face nowadays is, initially we had a lack of awareness, but now we have a problem for overdiagnosis also, because ceruloplasmin levels of 15 or 16 are being labeled as Wilson's and started on chelation therapy. So now we are on both ends of the spectrum. Majority of the patients are being diagnosed in adulthood, which leads to a increased morbidity and mortality, and there is a lack of access to genetic testing, and drug cost constraints are an issue in India. Liver transplantation workup also is a problem in our country, and we lack a pan-India registry of Wilson's disease cases, and there is inadequate rehabilitation and lack of Wilson's disease support groups in our country. And the take-home messages are, Wilson's disease seems more prevalent in India than what the literature suggests, and we have a marked heterogeneity in Indian population with a wide spectrum of mutations. That is the Indian paradox. P.C271 is considered to be the common mutation in India. We always think of hepatic and neuropsychiatric manifestations, but we always be careful about the other manifestations like renal, hematological, cardiac, and endocrine presentation. The main diagnostic tests include serum celluloplasm, tinniferous urinary copper, and presence of KF ring. And genetic tests are rapidly gaining popularity, and levels of exchangeable copper and relative exchangeable copper also are upcoming nowadays. And the Indian guidelines have modified the Leipzig score, and we have prognostic scores like NASA score, New Wilson index, and treatment options include chelators, zinc, liver transplantation, and plasma exchange bar Mars. These are the references. Thank you all for your patient listening, and have a great day.
We would like to hand over our certificate of appreciation to all the presenters over here. I request our patron, Professor K.R. Palanisamy sir, to hand over a certificate to Dr. Muthukrishnan. So Dr. Ham. Hand over a token of appreciation to Dr. TNISGTNC.
Thank all the chairpersons for chairing the session, and I congratulate all the postgraduates for presenting very well. I hope they also learn to stick to their time. I think it was wonderful, and I hope they write up this as case reports for our journals as well. Moving on to the next session, we'll start off with my secretary report. So I think ISGCon was well represented from Tamil Nadu, and we are proud to have that we have quite a few awardees this session. We had awards, and I congratulate the awardees as well. Professor K.R. Palanisamy, who got the Master of ISG Award. Professor Jayanti for the Best Reviewer Award from the Indian Journal of Gastroenterology. And Dr. T.S. Chandrasekhar, he was awarded the Dr. Balakrishna Clinical Excellence Award. And Professor L.V.K. was Krishnan was awarded the Fellow of ISD Award. And we're also proud to have wonderful postgraduate presentations who got the first prize in GI clinics. Dr. Deepa from Department of Pediatric GE Institute of Child Health, and first prize in liver clinics to Dr. Monica Muniratnam, again from Department of Pediatric GE Institute of Child Health. I think that's a way to go. I hope we had more awards to come in the future national conferences. And I would also like to congratulate and thank Professor Kandasamy and the team for successfully organizing the midterm ISG at Kutralam on the 19th and 20th of October. It was well attended. More than 200 participants took part in that. And we also recently had our ECME 6th session conducted on 21st of January under the guidance of Professor Kannan from Madurai Medical College. We had 2 interesting case presentations and a guest lecture by Professor Raki from ILBS. About 70 participants attended. I would request all the postgraduates also to make use of this, and I think there can be better attendance from the postgraduates. This is meant mainly for the postgraduates, and only 70 when we have about 100 postgraduates in Tamil Nadu. I would request them to make use of this opportunity to, we have guest lectures coming or providing lectures from outstations. I hope they make use of this platform. Tamil Nadu ISG research activity, I think the PLEX study is completed, it's getting analyzed. Dr. Alagamai is working on it. And there is a next study which is being planned on hepatocellular carcinoma. Professor Sumati is working on it, probably almost the Google form, everything is ready. Probably will be circulating shortly once it is finalized. key forthcoming meetings, our main annual Tamil Nadu ISD conference will be on 1st and 2nd of March 2025. It will be at held by under the guidance of Dr. L. Venkatakrishnan from PSG College, Coimbatore. We have an exclusive postgraduate program on 28th February 2025. Online registration for this conference is open. The last date for registration will be on the 31st of Jan. Please do register, and those who are registered will be provided accommodation as well. And all people, all participants, faculty and postgraduates are requested to register for the same. The call for abstracts and video digest are available, will be being circulated. It's on the website as well. The last date for submission will be on the 5th of February. The office bearer selection nomination is also open for the post of President-elect, Secretary, Treasurer, as well as 2 office bearer posts. And the postgraduate travel grant is the first time that Tamil Nadu ISD is starting off. It will be for 2 postgraduates who have a very good presentation. They can submit their research work to the society. So out of that, 2 postgraduate things will be selected for the presentation where they can present in an international forum, and that will give them a good exposure. And we also have Professor V.A. Mathan Award for Best Publications. So I'll request all the members to submit their publications in the last year for the same, and the TNISGTNC Rising Star Award for young consultants to come around. Also that registration for the conference is open. That travel, I will request the participants to take care of themselves. The other forthcoming meetings from the Tamil Nadu ISD group is the Digestive Endoscopic Week under Dr. TSC. It will be on 22nd and 23rd of February. We have Gleneagles Liver Transplant Society meeting on the 11th and 12th of April. And the scope meeting from the endoscopy, the GEM Hospital, will be on the 30th May to June 1st of 2025. So we have a lineup of a lot of academic activities lined up from the next 3 months. Please do participate and take care. This time we also fondly remember our patron who had passed off about 3 years back on December 12th. And we have a 4th anniversary of the GHEP journal, and I request Professor B.S. Ramakrishna, as editor, to give us comments. And just before he starts, we'll have a cake cutting for our things as well. I'll request Dr. Ubal, Dr. K.R. Palaniswamy, as well as Dr. B.S. Ramakrishna and Dr. Jayanti to please come over and do the honors, please.
Just about GHEP, I think you all are familiar with this. That's the website. I hope people are accessing it. The editorial board was changed this year in accordance with the practices that we are supposed to have. And Dr. Eapen and I'm the chief editor, Dr. Eapen and Dr. Paramnagam are the associate editors. And we have a reconstituted editorial board. So this is the summary of the publications in the last 4 years. What we need to focus on is that the number of reviews and original articles together per year, ideally we are trying to reach 25 to 30 per year. So we need more original articles, which is basically original articles and reviews. And I'm looking forward to all of you contributing something. Case reports are fine, but if we are trying to index the journal, then we need to have a minimum number of research articles published per year. So these are the 5 basic requirements for filing an application: to establish editorial policies, to follow these policies, publish on time and on schedule. That's something we are doing now. Publish sufficient volume of work annually, which is what I'm talking about, and editorial oversight and self-assessment. So what we need to do in this next year is to increase the number of reviews and original articles. I'm glad that the practice instituted by UBAL, which is to get reviews of the Indian literature, I think that's actually, we are getting regularly articles based on that. The article should be formulated properly. Even case reports, there's a care format that needs to be followed. So I request that all of you who submit case reports, please follow this format. And the other thing that we need is prompt and positive reviews from our reviewers. Positive as in helpful, not necessarily to just say accept it, but also helpful to improve the quality. Thank you.
Good evening to all. The first speaker for this session is Professor Biju from JIPMER. And we all know that he has special interest for portal hypertension surgeries. The topic is non-cirrhotic portal hypertension and surgery. And as you all know that Marion Clatworthy described 3 situations. You have a bad liver and a bad vein, good liver and a bad vein, and good liver and a good vein. I think he's, I don't know whether the concept still applies, but we'll hear from him.
Good evening, and thank you for inviting me, and it's nice to have a scientific talk in front of a very learned audience. So when we talk about portal hypertension, we generally start from bleeding, okay? So the disease starts from bleeding, but what we know is when we talk about systemic hypertension or pulmonary hypertension, we do not start from bleeding, okay? So this is one of the fundamental errors we had to correct in the management of portal hypertension. Bleeding is just one of the manifestations of portal hypertension, and we can't devise the entire management strategy of a disease based upon one of these symptoms. Okay, it has grossly affected the management of portal hypertension in the last 30 years. I'm just trying to make us understand what is the difference in this. So when you talk about etiology of portal hypertension, we talk about cirrhosis, non-cirrhotic portal hypertension, and EHPV. Okay. So this is the differential diagnosis. We put all these in one line: cirrhosis, non-cirrhotic NCPF, and EHPVO. But actually, the biology or etiology or disease tells that both of the other conditions are actually the also reason for cirrhosis. So you actually have to put NCPF, EHPBO, viral hepatitis, alcohol hepatitis like that, and cirrhosis one step below. So hope I am clear about what I am trying to communicate. Okay. So because one is a vascular disease of external liver, other is a vascular disease of inside. So we can't put a cirrhosis, NCPF and ESPO in the same line. This is fundamentally this concept is wrong. Okay, so that is the second concept which I am trying to correct. So when we talk about NCPF and ESPO, we also have to realize that these are also etiological reasons for cirrhosis. So now, compared to the other etiology of cirrhosis, why these diseases are different? Because when you talk about cirrhosis of other etiology, you talk about survival in years. Here, generally, we talk about survival in decades. So, all our etiologies, thought process, the management strategies, grossly influenced by the actual survival you get in these patients. So this has to be really kept in mind when we talk about strategies to manage NCPF and ESPO patient. We started using a term called NCPH, okay, but when you go to the actual etiologies, we know that both these diseases are really different. So these diseases are really different altogether. So when we assess about portal hypertension, we generally, in surgical point of view, we call it domain assessment. Okay. So the domains we assess, we know liver is one domain. We have to see. The esophagogastric varices is another domain. Unfortunately, it has taken a predominant that's the entire disease. We treat all these as G junction or gastric varices disease, which is wrong. Third is biliary system. We know that biliopathy and other diseases. Fourth is the spleen area. Okay. Now we also know that NCPH causes intestinal manifestation. That is also there. We also know that, at least in our center, we have observed that it also causes changes in the pancreas. Okay. So all these domains constitute the domains which are to be assessed and examined in every case of NCPH. So just a bleeding assessment and an ultrasound assessment of the liver is not enough to assess and decide the management strategy in these patients. Yeah. Third point is, when you see a next case of NCPF, why a cross-sectional imaging is very important in these patients? Because there are a lot of predictions and the prognosis of the disease you can make by a cross-sectional imaging. For example, some patients, you may have a right side dominant collaterals. Other group of patients, you have a left side dominant collaterals. And some patients, you will have pan-dominant collaterals. That essentially means that you are, yeah, that's fine. So there are several patterns you observe. So in our unit, if an NCPF patient coming with cirrhosis, we call them NCPH related cirrhosis. We started using such terms. Okay. So, and transplantation also may be required in some patients. Okay. So as I told earlier, this disease is chronicity in decades. Okay. So there is chronic cavernoma as well as an acute on chronic thrombosis. Both can coexist in these patients. Okay. So as I told, this is an ESPO patient. You can see that how the superior mesenteric vein is transformed to cord. Okay. So as we have excellent endoscopic maneuvers to manage the G-junction bleed or the variceal bleed, these patients are likely to survive long. And because of the long survival, they are going to have manifestations in other 6 domains which I told just now. Okay, I hope it is clear. So, why these patients have a sustained blood supply to the liver? That is because you have venous collateralizations all over. Okay, but it also protects the liver as well as it is deleterious to some other parts of the abdomen. So the problem with these collaterals are naturally designed to be protective, but they cannot replace a shunt because these collaterals further lowers the pressure. As it goes away from the liver hilum, the pressure comes down, the tortuosity comes down, and the walls will be very, very thin. Okay, that is the issue of the collaterals. So what I wanted to tell you now is high portal pressure, like pulmonary hypertension, like systemic hypertension, this is also one form of hypertension which manifests inside the body, and please do not equate with one of the differential diagnoses of upper GI bleed. This approach probably we have to change. So you can see what is happening in that vein. Okay. So you can go to our publication also. This disease is strongly associated with an atheromatous problem. Okay. So if you talk about EHPV and CPF, please do remember that we are dealing with a atheromatous disease. Okay. In our experience, 100% of the splenic vein biopsy has shown at least a myxomatous degeneration. Okay. We have a 65% histological abnormality in splenic arteries in portal hypertension. Okay. And also we have 35% association of splenic artery aneurysm in portal hypertension. So what we are dealing is, we are exactly dealing with the same manifestations of a systemic hypertension and also pulmonary hypertension. So that's why this hypertension is also a vascular phenomenon, not only a bleeding phenomenon. So you can see this atheroma intraoperatively very often. Lot of arterial and venous aneurysm. So these aneurysms causes stenosis. Okay, so this stenosis can also cause various manifestations in the abdomen, as I told earlier. Okay, so splenic artery, splenic vein aneurysm. So you can see the number of aneurysms in these patients. Okay, in this sort of extensive aneurysm, 13 aneurysm you can see. So we have 13 aneurysm inside the abdomen. Are we really worried about a G-junction bleed which can be easily managed by endoscopy? No. So this aspect of the disease has to be really taken into account when you manage the non-cirrhotic portal hypertension. And we also reported venous aneurysms. Okay, this is also part of the atheromatous process, part of the hypertension. So putting bleeding first for everything is a wrong approach in this particular group of patients. Okay. So hypertension and its changes, as I told, we are reported. These are our report about what are the atheromatous changes what you observe in the veins. So practically speaking, barring a few patients, no patient will have abnormal splenic wall. Okay. Why this atheromata is coming? Because these plaques are coming because of the intense pressure. Okay. This is a secondary phenomenon due to the hypertension what you see inside the vessel. Arterial abnormality also similar. So this is what I told, the 7-domain assessment. This is the assessment you have to do in every case of a non-cirrhotic portal hypertension, whether it is NCPF or EHPV. So all this evaluation you are very familiar. Why do we do contrast enhanced CT? Okay, so we can debate about whether ultrasound is enough or not, because to satisfy the 7-domain assessment, we need a contrast enhanced CT, and also it predicts the prognosis. For example, I will tell you a very typical example. Now we have a patient in the ward. This patient is 45 years. Okay, this patient blood once upon a time, that time endoscopically controlled. Okay, fine. Now he has carried the bleeding for 10 years. Now if you take the CT of this patient, there is not even a single collateral between the stomach and spleen. But he has developed extensive portal biliopathy. He has stone inside the liver. His superior mesenteric vein is calcified. Okay. Now, as I told earlier, this patient has progressed from a left side dominant disease to a right side dominant disease now with the disappearance of collaterals on the left side. So this happens because these patients, because of our endoscopic management, because of our excellent management of the bleeding, you are likely to see such patients in future. So these patients have to be managed by the strategies to reduce the portal hypertension. So these strategies help you to predict the course and also to decide the management. Okay. So reduction in portal hypertension becomes a priority. It is not a wise idea that you leave this patient with a high portal pressure inside the abdomen, creating risk of extensive atheroma all over the abdomen, and waiting for bleeding to put an endoscopic control, telling the patient that you are absolutely fine till you bleed. That is probably a wrong approach we are trying to adopt. Now, when we decide what is the surgical role in this patient, so normally very few institutions like us, we are what we call ourselves are pro-shunt people, okay. So we do, generally we categorize shunt as conventional shunt, unconventional shunt, and our own term we call desperate shunt. You have no other veins available, we take veins from here and there and do shunts in desperate situations. So these are the three categories generally we see. So these are the proximal spinoral shunt. Please do remember that when you talk about anastomosing to a normal vein, probably it is not going to happen. I have shown you the evidence. So practically we are anastomosing abnormal splenic vein or abnormal mesenteric vein to the systemic circulation, whether it is IVC or renal vein. Okay. So we continue. So a calcification on an abnormal vein wall is not a contraindication for any surgery in portal hypertension. So fall in portal pressure is the best sign of patency. Okay. As I told, our entire effort is to reduce the hypertension because it causes extensive damage inside the abdomen. Almost all of the studies very clearly show the single most important success story of shunt is the fall in portal pressure at the time of surgery or immediately after the surgery. So the diameter, as I told, it's not so important. The fall in portal pressure is so important. Now, from our experience, when we realize that we are not dealing with a simple patient of upper GI bleed, we also, in the concept wise, we try to change our strategy. We try to make these patients live with a reduced portal pressure. So as we know, several veins are diseased. So we try to search for alternate vein as well. One of the thing is you can also use adrenal shunt. So adrenal veins usually will be very big. Renal hilum will have so many abnormalities. So adrenal vein is a good vein. You can also use mesocardial. So mesenteric vein can be anastomosis inferior vena cava. This especially works in portal biliopathy because the distance between the liver hilum and the shunt will be very short. And you can also use interposition shunt, and you can also use synthetic shunt. You can even go to, so all these veins, what you see, small veins in a normal situation, these veins become big and big in portal hypertension, especially this sort of venous hypertension. So we have also done reoperations. As I told earlier, the shunt or interposition shunt use, that can also a significant proportion, maybe 13 to 17% go for thrombosis. We can also reoperate them and excise the thrombus or do another shunt also. Even the same patient, we have done 2 shunts at the same time. So this is one of the scenario where this is a PTFE graft. You can see how atheroma has developed inside the graft. These reoperation case scenarios are giving us further evidence that the hypertension persists, the atheroma develops further. So we have done revision shunt in this patient. Now, as I told just now, 5 minutes back, this anatomical topography is very important. So, why it is important? Because if you see a CT in portal ablation next time, you can prognosticate that if this patient has extensive left upper abdominal collateral, this is probably going to a more bleeding group. If this patient has extensive right abdominal collaterals, especially in the portal area, even if it is NCPF, these patients are going to have a portal biliopathy group. Okay? So, the right-sided dominant disease is much more going to be problematic in the near future, as I told, because we started controlling the bleeding manifestation much more effectively. So, it predicts, it gives the indication for shunt surgery also, and it also prognosticate the need for liver transplantation. Please do remember that you cannot simply convert these patients to liver transplant because we need vessels to anastomose. As I told, most of the vessels are diseased, especially the mesenteric vein and portal vein. If it is diseased, it will be very difficult to anastomose, and thrombotic rates are very high. So, we can also do some direct hepatic venostomy in portal biliopathy. Shuntable vein is less, and also you have a good window. Okay. So, we also will start seeing hepatolithiasis. One of the advantages of shunt in hepatobiliary in portal biliopathy is, if you reduce the portal pressure and reduce the collateral, it also helps in further endoscopy management. You see an ampulla which has less varices, you have bile duct which has less likely to bleed. So, this shunts in also helps in further management of these patients, either in the variceal front or in the biliary or stenting front. So, shunt still helps in that scenario as well. So, it gives a collateral, so you can also see that perform shunt and wait is also a good strategy. Okay. So, we also report that we assume that these changes happen only in the vessels, but we also have some cases where you can see that bile duct is also calcified. Okay. So, we wanted to do a hepatic venostomy in portal biliopathy, but when we opened, you can see that bile duct one also causes a calcification. So, what I wanted to tell again and again is, please do remember that this is a atheromatous disease what we are going to take. So, we are also in the surgical front, as you know that we have a conventional technique of ligating the splenic artery first, then manage the situation, and also we are totally saying that practice now. We do not ligate the splenic artery at all. We mobilize the spleen. We call it EMDAL procedure. The advantage is we could perform shunt in 98% of the situation. Okay, so if you operate 100 patients, only 2 you back out because of difference. So, shunt, there is nothing. We are trying to obviate a term called non-shuntability. So, once you open the patient, you will end up in doing shunt because of your change in technical strategies. We also added a procedure called a caudal pancreatectomy, because what really happens, you try to mobilize the splenic vein during surgery. As I told, these veins are diseased. You put your instrument there, you injure the vein, and that vein finally becomes not suitable for anastomosis. So, instead of mobilizing the vein, what we started doing it in cases where you need extra length of the vein, we just amputate the pancreas, remove the distal pancreas, and then you will get a long vein, and it can be easily anastomosed. So, we call it caudal pancreatectomy. So, this is one of the situations where you did like that. So, as I told, we did a spleno-adrenal shunt also. It's a easy procedure. Okay. And a third technique we added to this is, normally what you do is you mobilize only in this renal vein area. Instead of that, you completely remove the Gerota's fascia from anterior to the kidney. You will get lot of veins, and all your renal vein and its branches will be exposed. So, you can also use the abnormal renal veins for anastomosis. One advantage is you have a adrenal vein there. You also have gonadal vein, you also have inferior renal vein. So, all these veins can be used for anastomosis. So taking advantage of renal vein aberrations for shunt. So these are one of the extreme anomalies we encountered in that area. So 1/3 thrombose 5 years, but we also do remember that it doesn't mean that all these patients are going to bleed. Okay, these patients will have good quality of life. Now we have completed our quality of survey in patients who were NCPH. Okay, so we know that there is in children we have a growth retardation or delayed growth in patients with EHPV and NCPF. We also observed a similar phenomenon in adults. So what we do not want is, we do not want patients who are large spleen, unable to eat, early satiety, completely controlled by endoscopic EVL or other methods. He is not bleeding, but he is roaming around in our society with a large spleen, unable to eat and failure to thrive. So this pediatric equivalent of failure to thrive, we frequently observed in adult population, and that itself add another extended indication for splenectomy. When the large spleen is removed, these patients start eating. We have occasions where 1/3 of the patients really gain significant amount of weight also. And you can do reintervention in thrombosis also. So these are our results of this. 98% underwent shunt and a 96% correction of pancytopenia. Okay, these patients were living with, you are destined to live with low counts. If you think that this is the patient with bleed and we can manage endoscopically, you see the results of the shunt. So these are not bad results. So you can perform shunt. It also gives dividends of added splenectomy and correction of cytopenia. So surgery is not just for bleeding, and presence of pathological vein should not obviate the need of shunt. We also have to reduce the portal pressure, and now as in a trial setting, we also started using the drugs like propranolol to reduce the portal hypertension even if the patient is not bleeding. Okay, thinking that that may result in reduction in portal hypertension inside the abdomen. So what I wanted to tell in last half an hour is, probably we should change our strategy, put NCPF out of the bleeding armamentarium, put it as a different disease. Please do realize that these patients are going to live for long, and so we need long management strategies. The manifestations are there away from GE junction, which are likely to see. Many of them are non-transplantable ones, so we have to give a good quality of life. Please don't allow them to roam on with a significant cytopenia and large spleen in the circulation. We can correct it surgically. That's why in a good number of patients, we practically ignore bleeding as the only indication of surgery. All these things we put together, including our philosophy of atherosclerosis, and a good number of patients, we continue to do shunt surgery. That's what I wanted to communicate. Thank you very much, sir.
Thanks, Biju. Before I open to the floor, let me start with a question. From whatever you have said, are you trying to say that your concept is more in favor of doing a prophylactic shunt? Because even if there are no bleeding, you have a patient with a NCPF or EHPO, but patient is coming only with a massive spleen, hypersplenism, no bleed. You have a low threshold to offer prophylactic shunt.
So, first of all, the prophylaxis word is taken for bleeding. Okay, prophylaxis of what? So that's what I'm trying to tell. I'm going a step behind that. The prophylaxis word itself is taken from the algorithm of bleed first. So that approach itself is long. There is nothing called a prophylaxis. Yes, prophylaxis of bleed is fine. Like bleed, we have prophylaxis for cytopenia also is there. So that's not what I'm talking about. What I'm talking about is, we identify this as a separate disease entity. look for the all 7 domain assessment. Even if the patient is not bleeding, for example, as I told, currently the patient is not bleeding, but he has portal biliopathy. So a patient who is not bleeding, no portal biliopathy, still last clean, still hypersplenism, still we will do surgery.
I'll put it differently. What are all the cases of NCPF or EHPF where you will not offer shunt?
Will not offer shunt. Okay. So we observe the natural cause of the disease. So when we observe the natural cause, we do CT in all patients. Okay. None of the areas we are seeing any manifestation which is affecting either his quality of life or no frequent hospitalization or no active, no bleeding also, and no portability. These patients we observe. Because indirectly what we are trying to tell is these patients have a low portal pressure at that point of time. That is the inference and the philosophical inference we are deriving to put that patient on conservative management.
Okay. Floor participation. Yes, ma'am.
Ruxant? Yeah.
For EHPO, sir.
Yeah, Ruxant basically try to normalize the flow by anastomosing to the left vein, left liver vein, hepatic vein. So it is practiced abroad, but across India, all surgeons, what we see is the left vein, which is there in Indian patients, are practically diseased. So none of us get any normal vein there. That's why Ruxant numbers in India is hardly countable in fingers. That is the technical reason.
But in North India, some of the centers have started doing Ruxant in EHPO for children, sir. Because once they have, some of them will have growth retardation. So they are feeling it's better to operate early.
Yes.
I do not know in South India, none of them have started it.
So in pediatric patients, it works well provided we have a normal vein in the umbilical fissure. But a vast majority of the Indian patient, you will not get that vein. We all tried it and we all practically abandoned it. So I have done one only. Remaining patient could not get a vein.
So thank you, sir, for the enlightening lecture. It actually really changes the way we need to look at this NCPF. Sir, my question is, what is the anticoagulant protocol following shunt surgery? Because a sizable number they go for shunt thrombus. Do we need to give them oral anticoagulants?
No, I didn't hear the last part.
No, the role of oral anticoagulants. Should we put them on oral anticoagulants because there is a risk of thrombosis? The second one is, sir, because you identified athiroma in a sizable number of patients, do we need to give statins in such patients? Statins.
Statins, okay. So, regarding your second question regarding statin, in our last publication, we vaguely suggested that, but I don't have evidence to tell. Okay? We have discussed with our cardiologist multiple times, explained to him, what we have proved in pathology is, it is the same changes in the histology of a pulmonary vein and the systemic artery and vein you see here. There is nothing changed. It's the same change. So, question is, why are we not putting these patients on statin? Okay? So, our philosophy says that we can put, but I don't have evidence. But I do feel that future this is going to come, treating these patients on statin. Second, regarding anticoagulation, majority of the surgeons in India do not give anticoagulation. Our center we give. This is to make sure that the shunt is patent in the post-op period. Some patients, the side effect is some patients we have a small amount of ooze or bleed post-op. But these are completely manageable conservatively. We do not correct it from plasma. So if you ask me, our center, 100% of the patients, we anticoagulate them on table, 3000 units separate on table in NCPF, 5000 approximately in ESPVO, and post-op oral anticoagulation with a conversion to 3 to 5. So around 5th day we discharge them. What will happen?
Large varices?
Large varices after the shunt surgery, whether it will regress or esophageal varices, whether it will regress after a shunt surgery.
So, not in all. The reason is that's why we get CT. We have to identify the topography. We cannot manage the shunt just by blindly saying that okay, there are collaterals everywhere. We can manage any shunt. No. That's why we started classifying the right side dominant, left side dominant, and other diseases. For example, it is very often seen that the most common site of thrombosis is the junction of the splenic vein and superior mesenteric vein. If you have intense calcification there, your left-sided shunt which uses splenic vein, which is not going to give any treatment for portal biliopathy. Okay. So, let us say you have a SMV to IVC shunt you are doing, your collaterals on the left side may not regress at all. Okay. So, that is another reason what I was trying to justify earlier also. You have a patient completely only portal biliopathy. You have a thrombosis at the junction, atheroma is there, no connection between. You do a shunt on SMV to IVC on right side, you manage that patient endoscopically at the G junction also, if it is not controlled. Okay. That's why the 7-domain assessment is very important. You ensure that in your topography, shunt you are selecting is going to decompress all or most of the areas where collaterals are there. Okay. That's what I wanted to communicate.
In your follow-up cases,
I think
how many of
we'll
them
move on
had
to
a
the,
variceal bleeding later?
for lack of time, I think you can ask the questions later, maybe over dinner. So after that really fascinating talk, we'll move on to the next topic, which is approach to gastric varices from a radiologist, interventional radiology perspective. I think there was a time many of the youngsters may not know when gastric varices were a gastroenterologist's nightmare. But with the advent of interventional radiology, things are much easier. And I think Dr. Satish is one of the best persons to talk about it. He has vast experience, as we all are aware, and we benefit from it. So over to Dr. Satish.
First, I'd like to thank the organizers for the kind invite. Just for continuation's sake, what Dr. Prof. Biju was saying, I urge you also to look up something called as PVR tips. We were talking about rec shunt. So PVR tips is portal vein recanalization followed by a low volume shunt. So that has been there for about 10 plus years now, predominantly done in Japan and Korea. But nowadays in India, there are few centers which are doing it. Actually, technically, it is not very difficult because we are used to recanalizing totally occluded IVCs. So what the general concept is, the vein is so atretic, like what Prof was showing, that it's impossible to recanalize, which is not true. Because unlike an artery, a vein you can wire through in between. The only problem is then you'll have to put a covered stent through and through, which is a PTFE stent, very similar to the graft that they put. We can also put a PTFE stent and then put a small volume tips. The reason for the small volume tips is so that you are not leading to a high pressure environment. You are just putting a small volume tip so that the blood flows naturally to the right atrium. Besides the point. So I'll go to my talk now. So the mandate for me is to talk about interventional radiology approach to gastric varices. So this is just the basics. As you all know, portosystemic shunts may occur in isolation or in conjunction with, it's just a type of portosystemic shunt which may occur along with esophageal varices. So they occur in about 20% of patients who also have esophageal varices, and the risk of bleeding is significantly less, only 50% of that of esophageal varices. However, when they bleed bad, and you do not need very high portal pressures for these gastric varices to bleed. So the gastric varices can occur in the absence of cirrhosis, especially in a EHPVO setting or a splenic vein thrombosis setting. So they typically, the inflow to the gastric varices typically originate in the mid to distal splenic vein, and the outflow is usually to the left renal vein, IVC, or other intra-abdominal systemic veins. However, there are exceptions to this, which I'll show later on. So this is just a schematic which shows what happens when there is portal hypertension, blood is unable to flow, reversal happens, you get all the varices, spleen grows bigger, you get mesenteric vein thrombosis, and you get ascites and hydrothorax. So as far as IR is concerned, we have two major branches how to deal with this. One is occlusion, other one is decompression. So either you occlude the varices or you decompress the pressure inside the varices. So what are we talking about decompression? Decompression is classically tips. you can also do partial splenic embolization to decrease portal pressure. In our setup, PSC is not very preferred because of the infection rate. Following a partial splenic embolization, they can develop splenic abscesses. Though it is relatively easy to manage, it is something we generally don't offer as the first setting. And again, for partial splenic embolization to work, you have to embolize up to 50 to 70% of the spleen. Only then it will work. And that can, the post-procedure care and everything else is a little cumbersome. So I'm not going to talk about PSC, I'll talk more about TIPS. So these are all the different inflows. You've got the left gastric vein, posterior gastric vein, short gastric vein, gastroepiploic vein, all the veins supplying your perigastric varices. So what do we do in a TIPS? Basically, we just connect the portal vein to the hepatic vein. Classically, it is the right hepatic vein because the right hepatic vein is posterior and the portal vein is anterior, so it is easier to come from posterior to anterior when we are doing it from the neck. But you can connect it to the middle hepatic vein or even to the left hepatic vein if the anatomy allows you to do that. So this is what you get. You get all these blood coming in, also flowing into the varices and then causing problems. So this is what a TIPS does. It just reverses that by decreasing the pressure so that blood flows freely into the right atrium. So what are the indications? Acute or recurrent variceal bleeds which is unresponsive to medical or endoscopic therapy. So there is no rule for primary TIPS in any of these things. Obviously, you'll have to do your endoscopic management first. If that fails, then we move on to TIPS. Ectopic variceal bleeding, this I think is a very, very good indication because ectopic variceal bleeding are troublesome, they are difficult to manage endoscopically, and they do respond very well to decompression. So non-variceal bleeding for portal hypertensive gastropathy, not GAVE. GAVE, obviously, you're going to do your APCs, but if it is portal hypertensive gastropathy or enteropathy, then TIPS does work. The other indications which are non-bleeding is ascites or refractory, ascites which are refractory to medical treatment, unable to tolerate large volume paracentesis. Hepatic hydrothorax has got very, very good response. A lot of evidence for hepatic hydrothorax and intolerant to medical therapy. The other, obviously, there are other rarer, I wouldn't say rarer, Budd-Chiari is not very rare in our population. We do have quite a lot of Budd-Chiari where we do a DIPS rather than a TIPS. Hepatorenal syndrome, hepatopulmonary syndromes, prior to abdominal surgeries or procedures. The patient with large, like for the surgery Prof was showing, I can imagine it's going to be a difficult surgery because you are now opening an abdomen with a lot of portal hypertension inside it. If you can do a TIPS to reduce the portal hypertension and then they go on and do surgery. Many centers do that in the West. I mean, for financial reasons, we can't afford that here. And a bridge to liver transplantation. So this is one example. A 52-year-old male presents child's B, acute variceal bleed, underwent 2 sessions of glue, again presents with bleeding. So this is secondary now. Multiple settings has been attempted and not working, then we can offer a TIPS. So you can see the glue cast there. Those glue are from endoscopic injection. So we just do a TIPS, basically come from the neck, cannulate the right hepatic vein. From there, if you're lucky, within half an hour you can poke the portal vein, put a wire through and a pen, put a stent through. So this is pre-TIPS. You can see that there is the glue cast there. However, there are still a lot of varices around the stomach. And this is post-TIPS, 6 months afterwards. You can see that everything is now disappeared and it is decompressed. Answering the previous question, when you do a shunt, do these varices become small? They may become small, but if they are big, we will see what we have to do. So what about the results? So rebleeding rate is anywhere between 15 to 40%, but this is going back quite a bit in time because these are all the era of uncovered stents. Uncovered stents, the mortality is high, the reocclusion rate is high, but however, even with uncovered stent, the immediate hemostasis is very good. If you have got a patient who's acutely bleeding, you've tried your endoscopy, he's still bleeding, then TIPS is very good as a salvage treatment. So what are the problems related to TIPS? Durability, encephalopathy, decompensation, and rebleeding. What about durability? When we're talking about durability, reocclusion, instant thrombosis, this is a problem, but this is come down significantly with the covered stent era. These are all with bare metal stents. 1 year patency is a maximum of 60% and 2 years is only 30%. Shunt stenosis often and associated rebleeding can potentially impact survival. So many of these patients, when they come back with massive bleeding and then they could not make it, sepsis, hepatic decompensation. So you want to typically avoid this. So what about nowadays? Nowadays we have these covered stents. So this is called not fully, partially covered stent. So what happens is the distal 2 centimeters of the stent is uncovered, which you see there, the lower one is the portal vein. So you place the uncovered part in the portal vein and you place the covered part along the parenchymal tract. The theory behind why bare metal stents occlude is because when you're making the track through the liver parenchyma, obviously you are going to go through biliary radicals. Bile is going to leak into the stent. That is going to cause irritation and causes occlusion. So when you cover it with EPTFE, that bile leak doesn't happen, and the patency is much better. So a lot of papers have studied this. The probability of remaining free of TIPS shunt dysfunction is significantly higher with EPTFE coated. So nowadays, nobody does bare metal stent. Almost everybody is doing only this partially covered stents. Same thing with encephalopathy also. Free encephalopathy is also much better with this partially covered stents. So what about TIPS related encephalopathy? The main concern for all my gastroenterology colleagues is we do not do TIPS because you will go into encephalopathy, which is a valid and founded concern, 5 to 35%, which is not insignificant. So it does respond reasonably well to conservative therapy. If you conserve the precipitating factors, give them rifampicin, whatever, your lactulose and everything, and keep everything down. One other thing is, when you're doing TIPS for, when you're doing TIPS for hepatic hydrothorax, the decompensation is little less, whereas when you do it for bleeding, it is high. One of the theory that is presented is when someone has a large volume bleed, all the blood is still in the abdomen, is still in the bowel, and one's own blood is a very rich source of protein. That gets digested over the next 2 to 3 days, and they are going to have an increase in the ammonia release. So immediately after the TIPS, if someone has had a large volume of bleed, you may want to consider doing an enema and clearing out as soon as possible. The others, I'm not going to teach you all because I'm sure you know better. Refractory in about 3 to 7%. So what happens if there is refractory? You've done all this, still the patient keeps coming back with refractory hepatic encephalopathy. We can do something called a TIPS reduction, wherein we go inside and we normally put a 10 millimeter, so 1 centimeter stent diameter. After putting the stent, we can go back inside and then reduce it in size. We can make it 5 millimeter, 6 millimeter, depending on the various techniques. I'm not going to those techniques. So the goal of TIPS is basically reduce the HVPG or your photosystemic gradient to less than 12 mmHg. But too low is also bad. If you're going to go less than 5, then hepatic encephalopathy chances are very high. So you want to maintain that sweet spot of around 7 or 8, something around that. But it also depends on what your starting point is. If your starting point is 25 and you want to reduce it to a 12, that may not be realistic on table. So you may have to accept something like a 15 at that point in time. But over a period of time, when the body gets used to the new hemodynamics, the pressure will come down. What about variceal rebleeding? So this is one such case. TIPS done, patient again had a bleeding. You go through the TIPS stent and you can see that there is a big collateral. The gradient is only 5, but still this chap bled. So you go in and you embolize that, and he stopped bleeding. So there is very good evidence that when you are doing TIPS, you have to embolize the collaterals also. So doing the TIPS, if you see a collateral and you say, okay, anyway I'm decompressing, what is the need to go and embolize this? It's not a good idea, because we know that perigastric varices can bleed with low pressure also. The pressure does not directly translate to the risk of bleeding. So better to go and embolize. After this trial, which is about 2003, 2004 if I'm right, nobody is now leaving these varices alone. You do a TIPS, you embolize the varices, put the TIPS, and you come out. So adjunctive embolization, the added advantage is once you embolize the varices, now you are now having only a 10 millimeter shunt. You don't have 2 or 3 different shunts. So the hepatic encephalopathy comes down. The amount of blood that flows towards the liver is now increased, which means that the chances of liver failure or liver dysfunction is also reduced. What about TIPS related hepatic failure? Yes, this can happen. It can happen more so in a poor patient. So you have to choose the right patient. A patient with poor liver function already has hepatic encephalopathy, congestive cardiac failure, severe pulmonary hypertension. All these are obvious reasons why you do not want to do TIPS in this patient. If you do TIPS in this patient, they will go in for liver failure. So one of the papers just published. So the paper looked at the various hemodynamic parameters that change. The various hemodynamic parameters that change after TIPS. So after TIPS, what happens is the cardiac output increases. The cardiac output increases purely because now the preload is also increased. When you're doing a TIPS, you are increasing the preload. If you're going to increase the preload, the stroke volume is going to increase, which means the cardiac output will increase. So it is very important for one to assess the left ventricular function before a TIPS is offered. Not just looking at this, left ventricular function is also very important. So the only parameter that stayed or remained abnormal after 1 year was the blood flow towards the liver. So I'll also talk about which patients are suitable for tips, which patients do you want to offer tips. Okay, so the classic is going to be your MELD score. You use your MELD score and then you strategize and say stratification and say this patient is good or not. So MELD of less than 10 is ideally the best patient, but MELD of less than 10, I don't think you will see these patients coming in for tips. They are not going to have any problems, or they're not going to have bleeding and stuff. Usually it is around this 10 to 17 group, 14, 15, that is the range we usually look. So less than 10 is very low risk, TIPS is very safe. This could be the patients who's got EHPVO or other reasons, but KRE, things like that where you want to go and do. But if we are talking about cirrhotic or portal hypertensive patients, their MELD is going to be a little high. So 10 to 17, yes, these are ideal patients, you can do TIPS. 18 to 25 on a case-to-case basis. Is the MELD increase due to the acute illness? Is the MELD high because the patient now has an infection? Or is it because he's just bled? Is this correctable? If that is correctable and on the particular patient, it is worthwhile doing it, yes. High risk compassionate TIPS, 25 to 40. Definitely, first one is yes, second one is yes, third one needs discussion, fourth one is a definite no. There is no point. One thing I wanted to also emphasize is TIPS reduces the bleeding rate, has no effect on long-term survival. The survival, there is no survival benefit of TIPS. It's only quality of life, rebleeding rate goes down. The survival remains the same because the underlying disease is still cirrhotic liver and TIPS comes with its issues. So that's about decompression. Now let's go to occlusion. So the second big topic is variceal occlusion. Ideal in patients with poor liver reserve. For me personally, I look at if occlusion is not possible, only then think of TIPS. So if occlusion is possible, always go for occlusion unless there is already severe significant portal hypertension which would anyway need a TIPS. We will touch on that in a minute. So it redirects flow towards the liver and improves liver function. So occlusion of these varices is good. So how do we occlude? There are various types of RTOs, retrograde transvenous obliterations. The earliest is balloon occluded, which is BRTO. But nowadays we have PARTO, which is plug occluded, CARTO, which is coil occluded embolizations, which we'll talk about in a minute. There is also another called as ATO, whereas this is a retrograde, meaning you are going to come from the outflow of the varices and occlude it, whereas ATO is you come from the inflow of the varices and then occlude it. I will show you an example. So this is an example of a classic RTO, BRTO, whatever it is, a huge perigastric varices presented with acute bleeding, massive spleen. At this point in time, he was not fit for anything. So, and you can also see the gonadal vein, a huge spermatic vein, left spermatic vein that comes there. It's a male patient. So the way we do it is you can either come from the neck or the groin. My preferred is go from the groin. Go from the groin, cannulate the renal vein, and then find the shunt, cannulate the shunt. You can see the big gonadal vein coming down also. And then you put a sheath through that, and through that you put a plug. What is a plug? A plug is just a big nitinol mesh that is like a combination of multiple coils. So rather than putting multiple coils, you can just put one. This is very similar to your ASD septal occluders that we use in ASD, VSD devices. It's pretty much the same actually. So you deploy that, and the advantage is you do not have to deploy it till you are completely comfortable. The problem with coils is once you deploy the coil is deployed. If your coil is undersized, it is going to fly and it is going to be in the lungs. Whereas this, that is not a problem. You can wait, see whether it is occluded, and then you can slowly release it. So you don't release it, you can probably see it here that there is, yeah. So you can see that this is the plug. I don't know if you can see from the back, and this is still connected to the stem. So this is connected here. If you do a anti-clockwise 3 times turn, this will get disconnected. Okay. And then what you do is along the side of it, you put another catheter on top. So this catheter is now into the varices. The mouth of the varix where it is opening into the renal vein is occluded by the Amplatzer plug. And then you fill the varices completely with whatever you want. I tend to fill it with gel form only and not use sclerosant. That is the original description. Some people use sclerosant also. The reason why I don't use sclerosant is, if you can imagine, this is a huge varix, it is going to take a huge amount of sclerosant. And you do not know where the sclerosant is going. The sclerosant could still come down and then go into the lung and cause pulmonary hypertension. So better to just use gel form and just embolize it. So this is before and this is after. You see that entire completely is gone. the Amplatzer plug, this is the Amplatzer plug you see, even the spermatic vein is not seen much anymore. So the best part of BRTO is, unlike glue injection, it embolizes it completely. Whatever part 2 we see there, when we see them again, the whole thing is occluded. There is not small veins, only submucosal is occluded. No, the whole thing goes away. So it's very heartening to see that. And it also causes good redirection of flow towards the liver. Unrelated to this topic, there are a lot of papers which talk about improving liver function in patients with hepatic encephalopathy who have large varices. You occlude them, you redirect flow towards the liver, and albumin increases, their liver function increases, their hepatic encephalopathy settles. So what are the other, I told about ATO, right? So this is all outflow. We are coming from the outflow and we are embolizing it. How can we come from the inflow? So the same objective, it is usually when BRTO is not possible. So this is a case where you can see that there are a lot of gastric varices, pretty cirrhotic liver. And then he did have a gastro-renal shunt. We did cannulate the gastro-renal shunt. However, he had multiple outflows. So there is no point just blocking here and giving gel form because everything is going to come out. So the seal is very poor here. So you poke the liver, go into the portal vein, and this catheter is now through the inflow. This is the left coronary vein. So you go into the coronary vein, you see this is the inflow to the shunt. And then now you can embolize it with glue, coils, whatever you want. So this guy had coils and glue. And then follow up 6 months later, completely occluded, no perigastric varices. So yet another case, this is very similar to the previous speaker's talk. This is going to be a left-sided portal hypertension. This is a recent case, Dr. Preeti's case, 44-year-old man with chronic pancreatitis. He had recurrent melena and needed frequent transfusion. He had no large volume crashing bleed, but he did have nutshell bleed. So OGD showed few small gastric varices, nothing rip-roaring. CT showed features of chronic pancreatitis with an atretic splenic vein, multiple small submucosal gastric varices, and there was also a portal collateral to the left portal vein. So you see this here, this is the CT, and you see small submucosal varices, multiple small submucosal varices here. And then this is the splenic vein, very atretic small splenic vein distally. Proximally is okay, but distally it is gone. And you can see this small branch here, this is now a portal collateral that is coming from the left portal vein along the inferior surface of the liver and going to the stomach. Okay. So what CT doesn't show you, CT shows you this, but CT doesn't show you whether the blood is flowing like this or blood is flowing like this. So this, when we do an angiogram, which I will show you now, will make things better. So this again percutaneous axis of the portal vein. This is the portal vein you see, you've got a sheath in the portal vein. You go in there, this is the atretic splenic vein, go into the splenic hilum and inject. You can see this varices, perigastric varices. If you keep on injecting, you can see that this is now decompressing into the portal system. So this is a porto-portal shunt. So the outflow need not necessarily be a portosystemic. This is a porto-portal. Here, this portal vein acts as an outflow. Okay. So what would ideally we would like to do at this point in time is do a BRTO where the R is actually a portal vein. It is not the hepatic vein. So you go via this, occlude this, and then fill up this whole varices with a gel form. That is what I would want to do. However, in this case, it was very difficult because there was a small stenosis at this junction, and when you are trying to cannulate in a retrograde fashion, it is very difficult. It is like driving with the headlights facing towards you, and there is a dark road ahead of you. You don't know what is ahead of you. So the blood is flowing towards you, but you want to cannulate the origin. So it is very difficult. So did try, go into the portal vein. This is where the left origin is, multiple, spent about half an hour trying to cannulate that, not possible. So we decided to just go into the varices and just fill the varices with glue, which is what we did. All this is filled with glue. Injection from the splenic hilum doesn't show anymore. Fingers, keeping our fingers crossed and hoping he doesn't have newer collaterals and start bleeding again. Unfortunately, that is exactly what happened. 3 months later, though less frequent, he still had episodes of melena, HB still dropping and needing a transfusion. So he came back to us again. So there is no point doing the same again. You do the same again, we'll get the same result. So we wanted to do something different. However, we did get a portal access. This time what we did was we did an ultrasound to find that small collateral under ultrasound guidance, because on CT we know that the small outflow portal vein is just inferior to the liver surface. So you can see that small portal vein under ultrasound guidance, and you poke that percutaneously. So percutaneously the outflow portal vein is poked here, and then you manipulate a wire into the liver. Okay, so this is a vein, portal vein that goes from here towards the stomach, or the stomach is decompressing via this portal vein here. Okay. Now we have put a wire through that. What next? So we turn this wire and get it into the main portal vein like this. Okay. And through the portal access, you snare it. You can see a snare here, and you pull the snare, and now you've got a straight connection. So this is from the portal vein going into the collateral. Okay. Hope it's not too this. So the idea was just to try and help me cannulate this vessel, because earlier on we tried, we couldn't cannulate. This time we cannulated it from this side, and then reversed it and went into the collateral now. Gone into the collateral, injected. You can see that the lower part, which we embolized last time with the glue cast, is not showing any opacification. However, there are more newer collaterals on the top. So you can see that there is a bigger collateral here. So this here you can't use a part 2 because a plug needs a bigger vein to occlude. The smallest size plug is available is a 10 millimeter. Here it is hardly a 6 millimeter vein. So what you can do is a CAR-2. The same concept, but instead of using a plug to occlude, use some coils to occlude. So coils were put in, occluded, and the whole varices was filled with gel foam. So this is a CT 1 week later, and you can see that the coils are there. You can see a small cast here. This is the glue cast which we inject when we take the sheath out of the liver so that he doesn't bleed. And then you can see that here there are no, those varices, you can see faint hypo here, those are the thrombosed varices. And you can see the glue cast there, no major varices. You can see these coils here. And you can see this, that is the thrombosed portal outflow vein. Okay. So it has only been about 2 months, 3 months since we have done this procedure. So I'm hoping this will be the last procedure he needs. So in summary, one needs to, in terms of perigastric varices, the decision you need to make is, am I going to decompress or am I going to obliterate? My protocol is always try and obliterate. If you can't obliterate, do decompression. So you think of decompression when there are other sequelae of portal hypertension. The problem with obliteration is it is going to increase the portal pressure, because now you have occluded the varices, which means that all the blood is now going to get redirected towards the portal vein. About 50 to 60% of these patients will develop a small degree of ascites after the procedure. So you have to put them on conservative management, diuretics, or increase their doses of beta blocker. They do settle. If they don't settle, then you go and do a TIPS. Okay. So far, it has not happened to me that I had to do a TIPS after that. So TIPS versus A, BR, CA. A is ATO, which is antegrade. BR is balloon occluded. CA is coil occluded. PAR2 is plug occluded. Pre-procedure clinical status will also help you. Patient is very poor MELD status. You want to do occlusion rather than decompression. So no role of IR in primary prevention of bleeding in GVs. Secondary prevention with IR procedures have good outcomes with acceptable safety profile. Thank you.
Gastric varices. Any questions from the audience?
No, the presence of esophageal varices doesn't bother us because you are also good at managing it. So, but what we always say is before we do a BRTO or a CARTO, PARTO, whatever one of those RTOs, we would ideally like to have an endoscopic assessment before to make sure, because what the first point of redirection of blood flow after we embolize is going to be the esophagus. So what we don't want to be is we do the occlusion and the patient has a big bleed afterwards. So the literature and many big centers protocol is they will do endoscopic assessment 2 days, the day or 2 days before the BRTO, provided it is an elective procedure, and then they will do it 3 days afterwards. After the procedure, 3 days afterwards, you go in and have a second look before you discharge the patient. Or you discharge the patient, bring them back again, do an endoscopic assessment. If there are new varices, inject them or band them, whatever, and then send them back.
Sir, in the last case here, when you tried to enter that collateral, you went through the right portal vein.
Correct.
What about going through the left portal vein? That would have been easy.
No, I don't think it would have helped at all, because the issue was not because of where it came from, because the right would have been much easier, because you want to cannulate straight like this. When you come from the left, you're allowed to make a U-turn. You're coming from the left, which is this side, and this is going towards the stomach like this. So you'll come like this, make a U-turn and go. Making U-turns are always very difficult because you're pushing like this and you want the catheter to go like this. So that will not happen, it will go towards this way. So coming from the right side is better. But the problem here was, as I said, we don't know where the origin is. We are just blindly trying to hook. If it is a big one, like the gastric varices, the renal outflow, they are huge. So if you just do like this, your catheter will fall into this. Whereas this one is a 4 millimeter opening. A 4 millimeter opening may be very difficult to cannulate.
Thank you, sir. If there are last question.
So these varices are basically formed to decompress the portal pressure, and somehow it finds its natural path to decompress the portal pressure. Already the intrahepatic resistance is high, and again this BRTO is increasing the portal pressure, diverting the blood into the, then is there any chance of forming an ectopic varice while you are occluding this?
Yes. Same with your endoscopic glue injection. The risk is the same. We do the same.
Then the decompression procedure will be better than an occlusion procedure.
Are you willing to take the complications of hepatic encephalopathy, manage them over a period of time, all those things, bleeding risk, everything is there. See, the thing is, the problem with gastric varices, as I told, is it is not necessarily because of very high pressure inside the gastric varices. For gastric varices to bleed, you don't need very high pressures. The examples I showed you, HVPG was 5 millimeters. This was 8 millimeters, 10 millimeters. If you do a HVPG in many of them, their HVPG will be within reasonable limits, but they still have gastric variceal bleed. This is not like a esophageal bleed or an ectopic bleed. Okay. Now, ectopic varices in the presence of a patent portal vein is actually quite rare. Ectopic varices you see more in a EHPVO setting, more in that kind of a setting. It can happen, I'm not saying it won't, but the chances are less. If that happens, we can always go and manage. We know that a patient with portal hypertension, when he is bleeding, what we are doing is buying time. He's going to bleed again for sure. When he bleeds, we have to go and manage it. So that shouldn't really be a deterrent to doing these procedures. What would deter me from doing is massive ascites already. The patient has a lot of ascites. MELD score is normal or reasonably acceptable, but he's got a lot of ascites and he's got these varices. I'd rather do a TIPS.
Next topic is challenges in the management of variceal bleeding in Budd-Chiari syndrome. Dr. Kyle Willy, she's from Prashant Hospitals.
Thank you for the kind invite. I'll be talking about the challenges in managing patients with Budd-Chiari syndrome and portal vein thrombosis in respect to the variceal bleeding management. Okay, a brief introduction about Budd-Chiari syndrome. Budd-Chiari syndrome is hepatic vein flow obstruction that can happen anywhere from the hepatic venules to the cavoatrial junction. Primary Budd-Chiari syndrome when there is a luminal thrombus, web or stenosis. Thrombus can happen when there is a thrombophilic condition that is acquired or inherited, or in a state of hypercoagulability such as pregnancy or the usage of oral contraceptive pills. Secondary Budd-Chiari syndrome is when there is extraneous compression over the vessel secondary to a tumor or a space occupying lesion. Budd-Chiari syndrome, though rare, it can be life-threatening in some patients. The clinical presentation is very varied and non-specific. It can be acute to chronic, and this depends upon the rapidity and the extent of thrombus formation and the presence of decompressing collaterals. Patients with acute Budd-Chiari syndrome present with tender hepatomegaly, jaundice and ascites and elevated liver enzymes. Those with subacute and chronic forms, they present more like cirrhosis and their complications. Clinical examination may show hepatosplenomegaly, and the ascites is characteristically high sag and high protein. Patients with IVC obstruction have pedal edema and flank veins. Those with hepatic vein obstruction tend to have tender hepatomegaly and ascites. Brief note on the pathophysiology. When there is a block to the hepatic vein flow, there is venous stasis and congestion. This eventually leads to hypoxic damage in the centrilobular regions. This could lead to necrosis, and eventually fibrosis and cirrhosis sets in. So the goals of treating patients with Budd-Chiari syndrome is to prevent the extension of thrombus and maintain the patency of the vessel lumen. So recanalization and restoring physiological blood flow is our goal. Treating portal hypertension complications such as variceal bleed and ascites, and to prevent the progression of liver disease thereby. So there are a few differences between Budd-Chiari syndrome in the West and the East. Patients in the West tend to have an acute presentation. Patients in East, in Asian regions, tend to have chronic Budd-Chiari syndrome. And the segmented area of thrombus is long in the West, whereas in East it is usually short segmented. And this gives us a unique opportunity to restore blood flow whenever possible. So if you look at the hierarchy of managing, patients with Budd-Chiari syndrome in the West receive anticoagulants, and if that fails, endovascular recanalization is considered, followed by derivative procedures like TIPS and DIPS, and eventually transplant. Whereas in our set of population, we anticoagulate all patients and assess for feasibility of endovascular recanalization in all patients, and then move on to derivative procedures and transplant. We have to remember that patients managed by medical management alone, that is anticoagulants alone, respond only up to 10 to 20%. So let's move on to the topic proper. The challenges in managing patients with bleed, which is seen in about 5 to 20% of patients, is when to ban, when to start anticoagulants, what are the risks of bleeding when these are done together, what is the choice of anticoagulant, and what are the rescue therapies available in refractory bleeding. Let's start with the first one. So patients with acute Budd-Chiari syndrome presenting as bleed in the initial presentation, they have to undergo endotherapy first. Hemostasis has to be ensured and then started on anticoagulants. Those patients with acute Budd-Chiari not having a bleed have to be screened for high-risk varices and then started on anticoagulants, and if needed, a non-selective beta blocker can be added. Those patients with chronic Budd-Chiari syndrome, it's safe to eradicate varices first, followed by the usage of anticoagulants. So this is a paper from CMC Vellore that is looking at similar management protocol. They had two groups of patients, those patients presenting with variceal bleed and those without a variceal bleed. So those with variceal bleed underwent banding first, followed by endovascular therapy and anticoagulants. Those without variceal bleed, no prophylactic banding was done. Non-selective beta blockers was added if needed. And all patients underwent endovascular therapy and anticoagulants. So while on anticoagulants, those patients who had a prior bleed, 5 patients had rebleed. Those patients who never had a bleed before, bled in 3 patients. So, and if you look, we see that there are some form of stent malfunction in all these patients, and one patient didn't receive any endovascular treatment, reflecting that portal hypertension determines the occurrence of bleed rather than the anticoagulant themselves. And also the other parameters like time to variceal bleed after starting anticoagulants, overall survival and variceal bleed free survival were all similar in both groups. This is another study that is looking at the overall bleeding bleeding phenomenon that happens in patients with Budd-Chiari syndrome. 94 patients treated with heparin and vitamin K antagonists. 26 episodes of GI bleed were documented. And if we see that the provoked bleeding was seen in therapies like angioplasty, liver transplant, gynecologic procedures, even paracentesis, but variceal therapy was not seen as a reason for provoked bleeding. Just to say that variceal banding is safe in patients with Budd-Chiari syndrome, even though we are going to start them on anticoagulants later. There is no direct data on patients with Budd-Chiari syndrome regarding post-EVL ulcer bleed, but if we look at cirrhosis, the incidence of post-EVL ulcer bleed is at roughly around 5%, and it happens in patients who have high MELD, and when EVL is done as an emergency procedure, again reflecting that increased portal pressure is the reason for post-EVL ulcer bleed. So here the goal should be to reduce portal hypertension. This is an interesting paper that was looking at the role of genetics in determining if patients would bleed if started on anticoagulants. There were 2 genes that they identified, vitamin K epoxide reductase complex 1 and the liver enzyme CYP2C9. They found that mutations in these genes had a higher risk of bleeding than those patients without the mutation. So just an interesting aspect to this situation. The next challenge would be the choice of anticoagulant. The general practice is to start with low molecular weight heparin for a week or so and then bridge with vitamin K antagonist. Because we do not have much evidence in patients with liver disease regarding DOACs. Having said that, this is a paper that is comparing dabigatran in patients with Budd-Chiari syndrome who had underwent a stent placement. What they were looking at was the rate of stent patency at the end of 6 months. The results were comparable between DOACs and vitamin K antagonists, so were the rate of bleeding. DOACs are very attractive because they have a rapid onset and offset of action, and overall mortality and major bleeding episodes are also less in patients with DOACs, whereas vitamin K antagonists have a better safety profile in liver and renal disease patients, and rapid reversal is possible. The disadvantage being the high risk for bleeding and need for lab monitoring. For DOACs, there is, like I said before, there is no robust data like in patients with cardiovascular interventions, DVT and pulmonary embolism. There is good data, but not in patients with liver disease. And the antidotes also, I think it's not widely available. So the recent BCS guidance that came in 2021 APASL still suggests that vitamin K antagonist should be preferred for long-term anticoagulation due to scarcity of data for DOACs. So refractory bleeding is when we are not able to control the bleed during an endoscopic procedure or the patient rebleeds within 5 days. We could buy time with balloon tamponade or placing a SEMS and then aim for recanalization procedures like thrombectomy, angioplasty and stenting, derivative procedures like TIPS and DIPS, transvenous variceal obliteration and an attractive option for gastric varices. So different institutes have different protocols in managing the obstruction in their veins. Patients with IVC and hepatic vein obstruction, depending upon the length of obstruction, an angioplasty plus minus stenting can be done. For osteal stenosis, angioplasty alone may be sufficient. For long segments, then a derivative procedure like TIPS or DIPS may be performed. So this is a venogram that shows there is obstruction to the flow of the hepatic veins here. And after a plasty and a stent placement, we could see the opacification nicely into the IVC and the heart. TIPS, like sir discussed, it's a percutaneous radiological procedure that creates a portocaval shunt. It's more challenging than in patients with cirrhosis because of the thrombused segments in the hepatic vein. It restores physiological flow, thereby reducing portal hypertension and also improves liver function. So TIPS is also a rescue therapy and it's also a important therapy to preserve liver function as well. As good as liver transplant as seen in the study, patients with TIPS had similar 5-year survival to liver transplant. DIPS is when the hepatic vein remnant is very small, then a direct intrahepatic portocaval shunt can be done from the IVC into the portal vein. We can see in this ultrasound image, there's a needle that is coming out of the IVC aiming for the left portal vein, and then there is a guidewire that is going into the portal vein, and the stent a pathway has been created and the stent has been deployed. Moving to the second part, I'll be restricting to portal vein thrombosis secondary to, that is not due to cirrhosis or tumor. So looking at the cause, just like in Budd-Chiari syndrome, prothrombotic factors play a major role. In addition, local inflammatory causes like pancreatitis, diverticulitis, or appendicitis, even cholangitis can also complicate as portal vein thrombosis. The presentation can be recent or acute, and the complications are generally related to intestinal ischemia and portal hypertension. The goal here is again to prevent thrombus extension and reduce mesenteric ischemia. We should remember that varices can occur as early as 1 month after an acute portal vein thrombosis, and the management is similar to those patients with portal hypertension in cirrhosis. So those patients with recent thrombosis, which is less than 6 months, they should receive anticoagulants. Those patients with chronic portal vein thrombosis and have high risk features like a thrombophilic condition or ongoing progression of the thrombus or ischemia will require anticoagulants. And in these patients, we could eradicate the varices before starting anticoagulants. Having said this, there was a recent paper that came in 2022 that looked at patients with chronic portal vein thrombosis without major risk factors like myeloproliferative neoplasm, APLA. They were devoid of all these risk factors. So in these patients, they were randomized to receive either rivaroxaban or anticoagulants. The goal was to look for thrombosis-free survival in 2 years. In an unplanned interim analysis, they found that there was large number of new thrombotic events in patients not on anticoagulants. So almost 20 per 100 per year, where none of the patients on rivaroxaban developed new thrombosis. So this is an interesting study that things might change in the future that all patients with chronic portal vein thrombosis may require anticoagulants. Regarding the timing in anticoagulants, it's similar to patients with Budd-Chiari syndrome. Those with recent bleed, we should manage with endotherapy and anticoagulants. Those without bleed, we could start anticoagulants with or without a beta blocker. Those patients with chronic portal vein thrombosis, it's advisable to eradicate varices first, and next anticoagulants if major thrombophilic risk factors are present. So this is a paper from Garcia Pagan, just to look at the natural course in patients with non-cirrhotic tumoral portal vein thrombosis. 178 patients, they found 15% presented as bleed initially, and 15% had bleed delayed in their course of their illness. Rebleeds were seen in 15% of patients, and 1/4 of the patient bled while on anticoagulants. This is a systematic review and meta-analysis just to say that anticoagulants are helpful in patients with portal vein thrombosis. Though this analysis had a lot of patients with cirrhosis, unprovoked portal vein thrombosis constituted 1/4 of the study population. We could see that the rates of vein recanalization, thrombosis progression the rates of vein recanalization was high, and the rates of thrombosis progression and recurrent thrombosis were low in patients treated with anticoagulants. Also, there was no increased risk for major bleeding or overall mortality when treated with anticoagulants. Just to say that anticoagulants are safe in patients with portal vein thrombosis in terms of bleeding, and also offer much benefits to them. Again, the choice of anticoagulant, there are like Budd-Chiari syndrome, there is not much data. This is a study from the vascular liver disease interest group, where they observe patients with portal vein thrombosis. Of them, 1/3 had cirrhosis, child A. In these patients, they were treated with DOACs. They found that the rate of recurrent thrombosis and bleeding was low, as much as in 5% of patients. So they concluded the DOACs are safe and effective for patients with non-cirrhotic portal vein thrombosis as well. But the recent Bavino 7 guidelines says that the primary treatment option for portal vein thrombosis in the absence of cirrhosis is low molecular weight heparin and switch to vitamin K antagonist when possible. The recent, probably a few weeks back, there was an AGA clinical update on patients with portal vein thrombosis, and they have suggested that DOACs can be used in patients with child A and child B cirrhosis if they have portal vein thrombosis. Regarding rescue therapies, if the thrombus is very recent, then dissolution and aspiration, in addition to TIPS, may be performed. Those with chronic portal vein thrombosis, like sir was saying, PV recanalization, portal vein recanalization with TIPS, portal vein stenting, sometimes extreme procedures like transcollateral TRIPS may also be done. Easier said, but it's very challenging, I understand. Portal vein recanalization TIPS, here there is a large portal cavernoma seen by a leash of blood vessels. We could see there is a percutaneous transhepatic approach. We can see the guide wire into the portal vein, doing a balloon angioplasty, followed by a TIPS creation here, with a long stent that is extending into the SMV. So portal vein recanalization combined with TIPS. Another attractive option is portal vein stenting. Here there is a transplanic approach, the guide was coming here. We could see a short segment thrombus that narrowing stenosed part segment here. This has been dilated, and following the stent placement, we could see the blood flow restored here and the disappearance of the collaterals. So, to conclude, I will summarize. It is safe to anticoagulate patients with Budd-Chiari syndrome and portal vein thrombosis. As of now, the recommendation is to use low molecular weight heparin and vitamin K antagonist. Most bleeds can be managed by endotherapy. IR procedures can be definitive and also be helpful for refractive bleeding. Thank you.
Portal vein recanalization, is it usually only for bleed?
If there is ongoing tumor progression, the thrombus progression or mesenteric ischemia, then also again it may be considered. I do not know if it is also done for prior to liver transplant also. I am not sure about that.
Any further questions?
Thank you.
That was a very
Thank you. Thank you.
My pleasure to thank both the chairpersons for chairing the session. It was wonderful. I believe all of you will agree that it was a wonderful presentation by all the speakers. We had very good insights. May I request the chairpersons to honor our speakers. I request Dr. Shankar to honor Dr. Professor Biju Potakar with a small gift. Masai. May I request Professor Ganesh to honor Dr. Satish Ramamurthy with a shawl. I request Dr. Sarojini to please honor our last speaker with another shawl, please. Thanks. I take this opportunity also to thank the sponsors for this meeting. We had 3 sponsors, Abbott, Delvin and Fords, who have been kind enough to sponsor this occasion, and hotel management and all the AV who have been helpful in conducting this meeting. And I thank all the participants who have come in here to attend this on a Saturday evening. Though we have delayed by another 10-15 minutes, I think the dinner is open as well as the fellowship. Please join us for dinner. Thank you.